Good morning, everybody. Great to see you all here. Welcome to the Ex-Services Club. Great to see so many smiling faces. You're a lot quieter than what I thought you were going to be. Very well behaved. So a commendation to you right there. I know for some of you, it's been a little while since we've all got together and caught up. So maybe the noise will increase by the end of the afternoon. My name is Anthony. I'm from Western New South Wales Primary Health Network, and I'll be your MC for today, or bus conductor who says thank you a lot. But before I begin, I'd like to make sure that everyone's got their mobiles at least on silent. If you could do that, if you could do that for me, please, I'd appreciate that. And I'd like to begin today by acknowledging the traditional custodians of the land of the Wiradjuri Nation, on which we've gathered today, and pay my respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander peoples that are here with us today. And now to officially open this year's event, please make welcome Western New South Wales Primary Health Network CEO, Andrew Coe.
Good morning, everyone. Isn't it great to see everyone all together for a change, having been 2 years apart from not getting together. So let me start by acknowledging traditional owners of the lands on which we meet today, the Wiradjuri people. And I'd like to pay my respect to elders past, present and emerging. And I'd like to acknowledge those in the room who identify as Aboriginal or Torres Strait Islanders. It's my pleasure and privilege to be with you today on behalf of Western New South Wales PHN, in conjunction with Western LHD and with the National Centre of Immunisation Research and Surveillance. Welcome you all to this year's Nurse Immunisation Conference. It's wonderful that you're going to have Nick Wood and Katrina Clark from the centre later, and Priscilla Stanley and Belinda Tracy from Western New South Wales, so welcome. I'd like to thank Sulcaris, Pfizer and the Orange Ex-Services Club for their support for this event. I'm proud to be able to welcome you to this event, which unfortunately has not been happening for the last couple of years due to COVID. So I think it'd be a great opportunity for you all to get together and chat and network later today. Last 2 years have been very difficult, but there's been a great focus on immunisation more than in recent decades, and the importance of the life-saving qualities that they offer. Nelson Mandela reminded us of the lottery in life in which we are born, when he said, life or death for a young child often depends on whether he or she was born in a country where vaccinations are available or not. This year marks the 25th anniversary of the National Immunisation Programme, set up by the Commonwealth and State Territories in 1997, which isn't that long ago, which provides free vaccines for babies, young children, teenagers and older adults. Since 1997, population immunisation rates have climbed. However, this isn't solely about vaccines being made available. It's you and all the armies of dedicated health professionals that are determined to provide these resources and give our children the best start in life as free from serious preventable diseases as possible. Because of your work, our children regularly receive the highest immunisation rates in the PHN area and nationally. At the end of 2021, 97% of children aged 5 in our region were fully immunised, which I think is a great achievement. And for this, I offer you my congratulations. Your dedicated hard work and collaborative efforts during the past 14 months also helped create a safer environment for all our region's residents through the delivery and administration of COVID vaccination. Our region has got high rates of first and second vaccination, and I know your superb efforts will continue as we work to improve third dose booster rates and the booster rates that are coming through the winter strategy. Western New South Wales PHN is here to support you and your collaborative efforts with you, your partners, your stakeholders, as we continue to build trust in the COVID vaccination, shared trusted information, break down barriers for our vulnerable populations, and continue to lead by example. Next week is the mark it marks the 202 years, so 200 years since the birth of Florence Nightingale. The theme of International Nurses Day this year is a voice to lead, invest in nursing and respect rights to secure global health. We hope that what we do at Western New South Wales PHN honour the groundbreaking work of Florence Nightingale in pioneering modern nursing by supporting your daily efforts and ever-evolving developments of best practice execution of your life-saving work. Indeed, if you save one life, you're a hero. Save 100 or more, you're a nurse. I hope you enjoyed today and the learnings and networking that you'll have today. It's my pleasure to officially open this Western New South Wales Network Nurse Immunisation Conference. Thank you.
Thanks very much, Andrew. And yes, our first nurse immunisation conference since 2019. So there might be a little bit of refamiliarisation of a live conference event as opposed to a webinar where you can't turn your camera off or your microphone. We will all be able to hear you when you speak today, okay? So just a reminder about where things are. There's refreshments down the back. Of course, the toilets are located through the doors at the very rear of the room as well. You will find hand sanitizer on each of the tables around the room. We are encouraging everyone to wear masks if you'd like to today and observe social distancing so we can remain as COVID safe as possible today. Now, Slido will be in action throughout the day to help us with your questions for the presenters and also your participation in our quiz a little later on as well. So to join the Slido, all you have to do is scan that QR code on your program with your mobile, and you'll be able to use the Q&A tab to enter your questions for the presenters, and you'll also be able to like other people's questions as well, if you'd like to add weight to them. However, we do ask you that while the presenters are on, that you may hold your questions until near the end of their presentation, just so we make sure that we're answering questions that haven't already been answered throughout the course. Morning tea will be held from 10:15, lunch at 12:15, but there's a lot to get through between then and now, including our first presenters, who indeed have a wealth of expertise and local knowledge. Both Bachelor of Nursing graduates. Priscilla worked as an RN in a tertiary referral hospital in Sydney, a major regional health facility in remote North Queensland, and smaller private hospitals before settling in Dubbo. And Belinda, who is a lifelong Central West local, who has largely been in charge of keeping our kids immunised over the past 3 years, and indeed both have been instrumental as part of our region's COVID-19 response. To present on local immunisation coverage rates, the COVID-19 response, the school vaccination program, and updates to cold chain breach reporting, please join me in welcoming from Western New South Wales Local Health District, Director of Public Health Unit, Priscilla Stanley, and Clinical Nurse Consultant Immunisation School Vaccination Program, Belinda Tracy. Priscilla and Belinda.
I'll go first and then Belinda's tagging in. Isn't this amazing? I don't know about you, but I'm really excited to see everyone today. I couldn't remember when the last conference was, but 2019 feels like about a decade ago. COVID has really mucked up our perception of time, I think. So for those that don't know me, I'm Priscilla Stanley, the Public Health Director at Western New South Wales Local Health District. There are a few familiar faces in the crowd, so lovely to see those familiar faces, and welcome to all the new faces. There has been a bit of a changing of the guard in public health with our senior nurses. Belinda's been introduced as our CNC for immunisation. So for those of you that know Kerry Bout, Kerry has taken her leave, so she's on long service leave now, pending her next stage of her life, so into retirement. So Kerry leaves behind big shoes to fill that I have no doubt that Belinda's going to step in or has stepped in already and will be running. I'll start by, and I'm only meant to be really brief, so I will get cracking. I'll start by acknowledging the traditional custodians of the land on which we're meeting and pay my respects to Aboriginal people past and present, and any Aboriginal people attending today. So welcome and thank you very much to the PHN and NCS and Sequiris for today. It's wonderful that the local health district can come and present and provide you with our update. I promise I'll be brief, and public health unit staff that know me, don't laugh. There are presenters much more exciting than me ahead for you today, so I'll speed through what I've got to talk about. I just want to firstly acknowledge the tremendously difficult period we have been through in the last 2 years. I have absolutely no doubt that's affected each and every one of you, both professionally and no doubt in your personal lives as well. It's been a really, really massive couple of years. So I just want to pause and for everyone to reflect on the efforts you have made in your professional life as health professionals in working really hard to stop the spread of COVID. So there may be many of you that have thrown some COVID vaccines into arms, which is fantastic. For those that weren't involved in the COVID vaccine rollout, there's absolutely no doubt in my mind that you've been continuing with the normal vaccination program as best we can, given the circumstances. Hopefully you've all received your COVID vaccine, and probably if you haven't, you probably shouldn't be here today, but I'm pretty sure, I'm pretty confident that the uptake amongst all of us is at 100%. Other activities that you would have all been involved in over the last 2 years is that physical distancing, the washing of our hands, and all the other public health messages that have been put in place to help stop the spread. So well done to all. And I actually want to take the opportunity to give you all, and for all of you to join in and give yourselves a big clap. So last week we had World Immunisation Week. So it was from the 24th to the 30th of April. And as Andrew pointed out, we've got International Nurses and Midwives Day next, I think it's next Thursday, if my memory. Oh, it is today. Oh gosh. Midwives Day today, nurses next. Great. So congratulations to all the midwives out there. Yes, oh, there's a table of them right here. So the theme, the World Health Organization had a theme of long life for all, and the aim of Immunisation Week was to highlight the collective action that's still needed, and also to promote the use of vaccines to protect people of all ages against disease. So, I mean, that's something we're all very, very well aware of. But there was something written on the World Health Organization website, and I encourage you, if you haven't been onto the World Health Organization website, go and check it out. It's got some really great resources and some really wonderful information. But I wanted to read this to you all so that you are all very well aware of the efforts that you make in the world of immunisation, and don't for 1 second underestimate the huge impact that you have on individuals and the population. So a long life for all is not a promise, it's an ambition. Because everyone deserves a chance at a fulfilling life, one where we're free to pursue happiness and look back without wondering what if. Vaccines have been indiscriminately saving lives since 1796. The first smallpox immunisation was a fight back against disease. For the first time, it gave everyone a chance. And hundreds of vaccines later, across 2.25 centuries, billions of lives have lived longer lives. They've grown to become firefighters, doctors, musicians, fathers, mothers, brothers, sisters, and of course nurses. Vaccines might not get credit for that first kiss, that winning goal, that special day, that final hug, but their worth isn't just measured in doses given, it's in minutes given back and lives prolonged. Vaccines provide opportunity and hope for all of us to enjoy a more fulfilling life. And that's something we should all be fighting for. Vaccines in the pursuit of a long life well lived. I will hand over to Belinda now, who's going to provide some key facts and information on our local coverage. But it's interesting just to note that the impact COVID has had globally that an estimated 23 million children under the age of 1 have not received their basic vaccines. So that's the highest number since 2009. In 2020, the number of completely unvaccinated children increased by 3.4 million. 1.6 million more girls were not fully protected against HPV in 2020 compared to the previous year. So that's a huge number of people and very vulnerable individuals. But I want to hand over, I'm ending on a really low note, but I know Belinda's going to give you some wonderful data and facts about what you've all done locally. Thanks, Belinda.
Hello, thank you, Priscilla. So I'd like to introduce myself. I'm Belinda. I've been put in the position of C&C for our area, so bear with me. And so today, as you can see, we've had our Public Health Director update, and then I've got all these topics to cover. So bear with me, I've got a busy half an hour, so I hope that the stats that I've got to show you this morning just prove how well everybody has done, contrary to some of those stats. So I'm going to start with the local immunisation coverage rates. So they've maintained at a high level during 2021. This data reflects the coverage rate for Western New South Wales and Far West. It has been provided by the PHN. So this quarterly data shows the rates of immunisation for the 12 to 15 month cohort. And as you can see, every single quarter is above 93%. Both Aboriginal and non-Aboriginal children have maintained a high rate throughout the 2021 year. So this impressive rate, the PHN have let me know that this group has remained at the highest level across Australia. So this is quite an achievement. So it's something to be very impressed with. And we'll move on to the next cohort, the 24 to 27 month cohort. Here we have the rate of these children. Traditionally, this cohort show a dip in coverage rate. This is perhaps due to parents getting busy with life and simply falling behind in their children's vaccination schedule. But nevertheless, the vaccination rates remain above 93% in all quarters for both Aboriginal and total all children. This next slide is the 60 to 63 month cohort. These statistics speak for themselves. Catch-up programs, opportunistic vaccination, and hard work have produced these very impressive coverage rates. It is pleasing to see these coverage rates this high and higher rates for Aboriginal children. After morning tea, there will be a closer look at vaccination coverage rate for Aboriginal kids with Katrina, but you can see there that at 97% and above for every quarter for both all children and Aboriginal children is a testament that by the time these kids are off to school, they are well and truly covered. So it just goes to show you how impressive things have maintained during the pandemic in 2021. Let's skip the slide. Let me see if it's just missing. I've got an IT issue. No, it's gone. Anyway, it was just a slide that showed all of those cohorts together. So yeah, regardless of the nightmares of the COVID pandemic, people in the child and family health world, GP land, you've all done an exceptional job in making sure that our children under 5 have been very well vaccinated. So well done. So the school vaccination program is what I'm going to move on to now. So these few slides, I'm sorry, lots of slides, lots of numbers, are just going to demonstrate the success of the school vaccination program during 2021 as well. So just to remind people, the school vaccination program offers Year 10 a meningococcal vaccine, and Year 7 are offered Boostrix and a 2-dose schedule of Gardasil 9. So here we have the Year 10 meningococcal vaccination rate for Years 10 in 2021. So the coverage rate for New South Wales was just 60%, seen in the red there. So Western New South Wales was 64% and Far West was 36%. The school vaccination program was heavily impacted by the lockdown periods, closure of schools and pausing of the program in some LHDs. Throughout Western New South Wales and Far West, the program still continued, but with low school attendance rates due to COVID, it impacted the overall coverage rate, but nevertheless, still an impressive rate given all the lockdowns. So here we have the female Year 7 HPV vaccination rates showing dose 1 on the left and dose 2 on the right. So the red line is showing the New South Wales total dose for dose 1 and dose 2. So as you can see, dose 1 at 82% for the total, we weren't having such an impact from COVID, but as you can see, the 23% for dose 2 definitely demonstrates that lack of access to schools and the shutdown of the program. So yeah, it was definitely impacted by COVID. So yeah, Western New South Wales was at 85% for dose 1 and 70% for dose 2. So we still did quite well because we were able to just still get into some schools. So well done to everyone in our outlying communities who were still able to get into their high schools. So this is the males, again, much the same impact. And you can see there that, yes, 79% for the New South Wales total dose 1 and 22% for the dose 2. But yeah, definitely some 0% there for dose 2. So those areas stopped the program. And finally, for the Year 7s, the Boostrix, 78% was the average for New South Wales, and Western New South Wales was at 82%. So Catch Up is a big program for this year to try and close that gap of missed vaccines. So it's offered at every school we go to, and but I think if you're working in that GP practice, child and family health space, you might get a lot of questions from mums and dads. So you know, you can definitely offer that catch up in that space if need be. So just checking on the air or ringing the public health unit, we can help identify if those children have had dose 1 at a school or elsewhere. So the catch up program is well and truly in swing, and trying to catch up the difference for that 2021 shortfall thanks to COVID impact. So the school vaccination, where to next? Well, yeah, as I mentioned, it's a major catch-up program, but for those of us that have been working in the COVID space, we've been using electronic consents, and that is going to be introduced into the school vaccination program. So we're in the planning phase right now, introducing that into the school program. So hold tight, and we'll surely be giving that information when it is ready to roll out. So, but lots of training and support will be provided by the public health unit and all the awesome leaders out there that are sitting in this room to transition into electronic consents. This is very, very, very brief, and I just wanted to bring people's attention that the cold chain breaching report form has just been recently updated, as in last month. So there's going to be a copy available today on the table down the back, I believe, as well as an electronic link to an email that will come out from the PHN. But the flowchart hasn't changed, that remains the same. But the cold chain and vaccination wastage report form, that's just a little bit tweaked. So you can complete that online if you like, or you can print it off any which way. And then on the final page, it just gives you a phone number where you can ring the public health unit to report that cold chain breach. And I'll give you directions on where to send that after you send that through. So I hope it's familiar to you. But yeah, I think it's a pretty self-explanatory form. But yeah, I'll be on the end of the phone if you've got any questions. Okay, so the big chunk of my time is going to be on the COVID vaccination rollout in our LHD. this has consumed my life for the last 12 months, and I'm sure it's consumed a lot of everybody else's lives. As Priscilla has indicated, yeah, it's been a pretty crazy roller coaster ride for everybody in this room. So yeah, I think we've all played an important role. So as healthcare professionals, we've definitely had an impact. Every single person in this room has contributed to keeping your community safe during this time. Something I think we can all be very proud of. Prior to the rollout of the vaccine, we dealt with the uncertainty of living with this virus. Communities were scared, and as Priscilla's mentioned, the challenges during the last couple of years dealing with all the elements of a pandemic have definitely had an impact. So by the time we got our hands on some vaccine, there was a lot of anxious people, a lot of uncertainty. So it was, yeah, a big project. So the timeline here indicates that the vaccination planning started in January 21. So that planning involved, I'm going to mention names, Leanne Casey getting identified as a lead in the program. And poor Leanne had the task of putting together a team, and the pharmacy working out how Dubbo became a hub for storage and distribution of vaccine for our LHD. So yeah, that was the beginning of what has been a very long and arduous task, but we're still here to tell the story. So that's the main thing. Initially, the obligation, it was thought for the LHD, was to vaccinate residents of the aged care facilities in our MPSs of our LHD and the staff employed across Western New South Wales LHD, which, you know, was planning about 7,000 doses of AstraZeneca. So there was recruitment and training of nurse immunisers and admin staff, learning the software programs for bookings and vaccine administration recording, as well as undertaking the Commonwealth training packages for each vaccine. The logistics of storage and transport of the vaccines, freezers, fridges, consumables, everything you can possibly imagine. It was an enormous task. And a Commonwealth-led program changed every element of vaccine ordering and accountability. It quickly came to light that demand was outstripping vaccine supply across the LHD. So the Public Health Unit actually performed a pilot for a community-facing project, and we went out to Trangie, Tottenham, Trundle and Tullamore in April 2021. This pilot was very successful and was the beginning of the community-facing clinics in the local health district. Eventually, the public health model was integrated into the staff and RAP program, and we've been working as one for the last year. As the timeline suggests, there were many ongoing changes throughout 2021 and into this year as well. Advice on vaccines changed, different vaccines became available. Every change required a change in planning for the COVID vaccination rollout. So that, you know, this little slide here sort of just demonstrates all of those things, and I'll continue talking to that slide as we move along. The Western New South Wales Local Health District is a large geographical area. Dubbo was identified as the initial hub for the area. Orange and Bathurst were also then set up with hub clinics. 3 mobile teams were created, the concept being one team in each identified sector, northern, central and southern areas. So those circles are identifying that northern, central and southern, and the yellow is identifying the hubs. So we had to adhere to lots of Commonwealth vaccination modules, training in multi-dose vials and low dead space needles, continually requested to take on increasing numbers of police, fire, hospital staff from private facilities. So as you can see, Western New South Wales is home to a lot of people over a large area. So trying to get to all those people in a timely response when everyone wanted a vaccine yesterday required a lot of planning and logistics. So we got creative. We took those hubs, we put them in cars, we moved around, we put together an awesome team. people that basically stopped living their private lives and jumped in a car and started driving around the district. It's been an amazing experience. We've met an enormous amount of you all in this room. So, you know, I think that's the silver lining from the whole project is that, yeah, I think we've realised that we're all human. We're all in it together and we will get through it. So when we start talking about mass community vaccination clinics, you know, in the school vaccination program, we're used to doing 100 or so kids here and there. The clinics started in a various different sort of model. They were small to begin with, as people were trying to identify who was eligible for vaccine at what time, what vaccine was available, doing their research. And we weren't, as the community as a whole, weren't looking for the COVID vaccine. They started shopping for brands, which was a totally different language. And it made it a challenge. So the mass community vaccinations, they started to hot up when people got trust in the vaccines that were coming to the district. They were run in local halls and showgrounds typically. Local councils were heavily involved in site selection and support on the day to ensure that the populations were safe. There was parking, there was waiting spaces, there was social distancing, the list goes on. So eventually they become very heavily booked, which was great. We also had limited vaccine supply, so we had to be very mindful about wastage. It was just a precious, precious resource. So we had to significantly increase our workforce and maintain a really good relationship through all the district with the councils and the local emergency management officers, just to try and get these things set up. So basically it was a hub and spoke model, and we were the only LHD in New South Wales using this model. And I'm probably proud to say that it worked very, very well. So yeah, they were a lot of fun, and we processed a lot of people. So the hubs in the 3 areas were very busy. They had the booking system, they were static. So based in the larger towns, they definitely had some throughput of all ages and all vaccines. The Dubbo hub was expanded to include a drive-through vaccination clinic after they moved to the showground. This large shed just gave the population in Dubbo another alternative for accessing the vaccines. So this provided opportunity for people with disabilities to attend, so they could be vaccinated in their car. So that was, a welcome change. And there was also a high uptake by Indigenous populations. So that really helped break down those barriers and improve the access for those cohorts. So in early August, regional suppliers of Pfizer were redirected to Sydney to vaccinate the HSC students. I don't know if anybody remembers that. So just as we thought we're all planned and ready to rock and roll, bye-bye Pfizer. So in-house, it was just, no Pfizer for you. No one could get it. So we had clinics booked with, a varying number of bookings because of the locations, but it was a really stressful and devastating time when we had to let our booked people know that, sorry, you're booked for Pfizer, but we can only offer you AstraZeneca. So that really was a challenge. So things got busy, and we decided that, the model was going to get bigger and the demand was going to be even greater. So the enormous workload was ongoing, and with that, lots of conversations were had, and on the 7th of August marked the arrival of the Omicron wave west of Sydney, with our first confirmed case in the LHD. So AstraZeneca was not trusted, Pfizer was gone. The news were angry. So negotiations led to the arrival of the ADF. I'm sure you all remember that. So the ADF provided doctors, nurses, medics, and general duty officers. This put planning into overdrive, and suddenly we had 5 vaccination outreach teams per day for 7 days a week for about 6 weeks. It was absolutely nuts, but it was a good ride. So Western New South Wales Local Health District was the lead, and the ADF were the workforce that we desperately needed to improve our mobility to increase access to vaccine for communities. GP clinics were booked to capacity, as were our clinics. People wanted vaccine. So we were very grateful. Once the ADF put on deck, our Pfizer came back. So COVID-19 vaccination rates for eligible groups was climbing quickly. Footy fields were full of tents. Showgrounds quickly became the sites of long queues, as in excess of 400 people at some clinics were vaccinated in a day. So it was just a really massive project, and anyone that was involved at this point, either in your GP practice or in these clinics, everyone was really head down, tail up, providing the vaccine that the communities that you lived in, they got what they needed. So it's going to be a project I'll forever hold on to and remember fondly, as much as it was absolutely crazy. So then we started identifying that the drive-through clinic in Dubbo offered our vulnerable groups some great opportunities, but there was more than Dubbo to be concerned about. So vulnerable groups were soon our focus. These groups included the homeless, displaced individuals, disability groups, Aboriginal communities. So difficulty in accessing providers was identified as the major barrier as to, trying to get to a GP surgery or an LHD clinic. So this is when we introduced our really mobile clinics. So we went and got 2 mobile motorhomes, as you can see. And we affectionately nicknamed them Jabba and Spike. So they were basically set up as a mobile clinic, and we just took them wherever we felt we could have an impact. These vans were taken predominantly into small communities in the northern regions of our local health district, but also visited locations throughout the area. Burrendong Dam, you name it, we went there. So home visits were also offered via these vans as well. So we also offered home visits at any time when we were in a town, just by jumping in the car and making that happen. So we really relied on the locals. So, there's plenty of you in this room where I'd ring and say, we're coming to your town, can you help on the day? And I appreciate every single person that downed their tools from their busy business as usual, but also took on the challenge of helping a day here and a day there in a clinic as such as this. To increase our workforce, allied health practitioners and Aboriginal health practitioners were given the authority to vaccinate with the COVID-19 vaccines after training was undertaken. So from about the 1st of November, this extra workforce came into action with actually giving the vaccines, because as you can see from all the stats that I've shown you thus far, immunisers were busy across the district doing all the programs on offer. So this extra workforce was a valuable increase in our ability to offer remote clinics across the district. And they continue to work in this space today with ongoing clinics. Having local faces promoting and discussing COVID vaccinations and the clinics in towns across our district certainly contributed to the success of the community-based clinics and subsequently getting the vaccination rates to the level they are. I could truly show slide after slide to demonstrate the uptake of each vaccine for each cohort, but that may lead to death by PowerPoint. But here are some simple facts just to give you a bit of an oversight of where we stand. Ooh. Okay, so this one here is the COVID vaccination rates for 16 and over. This data indicates the high rates across the state. Western New South Wales is above 95% for both dose 1 and dose 2. But as you can see, as a whole, the vaccination rate for dose 1 and dose 2 is quite incredible. So just to focus on certain aspects of that overall rate, this is the pediatric rate for the 5 to 11 cohort. This pediatric rate is still lagging, but as parents learn more about the vaccines and increase their confidence, it is hoped that this rate will continue to rise. So currently we're sitting at dose 1 at 46.2% and dose 2 at 32.5% as a whole. But that sort of just gives you an idea of LGAs. So I'm sure you're honing in on your local district, but it's data like this that helps us identify the areas of need. So that's where it's very useful. So this was from only just a few days ago. And then to hone in on it just a little bit more, here's our Indigenous rate for the same cohort. And it has got a drop, unfortunately, but with yarning circles and engagement, with lands councils, AMSs, they're just some ways we're trying to advocate the safety and effectiveness of vaccines for our Indigenous families. This remains a focus area for the COVID vaccination rollout. So yeah, so we've got some catching up to do there, but over time and patience and good advocacy, I hope that rate will increase. So this is the 12 plus for dose 1 and dose 2 by LGA. And again, very impressive numbers there. So dose 1, 99.7%, dose 2, 98.3%. When I first looked at these statistics, when you see the 100%, you sort of wonder how on earth can we get 100% when, you know, that's nearly impossible. But after I spoke to the lovely number crunching people, the population numbers are based on the 2016 census data. And they've basically said once the number of vaccines given in an LGA, once they reach that population, it just automatically goes up to 100%. So that kind of explains it. But so yeah, stats are great, but they're not always perfect, unfortunately. But nevertheless, it just definitely indicates that we've got that coverage there for dose 1 and dose 2. And just honing in on our Indigenous for the same cohort. And again, dose 1, 84.3%, dose 2, 81.6%. I'm sure there's probably some statisticians out there that would love to see that higher, but you know, I think that's a really positive outcome for our Indigenous group. And, you know, there's a lot of fear sometimes in our Indigenous families and groups and communities. So that's just a testament to the hard work of all of our practitioners out there doing their thing. The booster dosing, I haven't got a slide on it, but booster dosing uptake has been mixed across the area. It's still sitting at 65.7% across Western New South Wales. So the ongoing vaccination program to offer booster doses is truly a collaboration of all providers across the local health district. The intensity of the rollout has settled, but the demand and, you know, the demand has declined a little bit, but communities are transitioning into using their local providers and trusted healthcare professionals to discuss and receive COVID vaccination. The local health district is providing ongoing clinics for residents of our RACs and communities who have identified low or poor access to vaccines. The local health district is here to support the ongoing rollout that has been led by GP practices, Aboriginal medical services, pharmacies, and the PHM. The local health district Aboriginal health practitioners are continuing to engage with Aboriginal communities to promote vaccination as well as education about other health management strategies. So yeah, so moving forward, it is going to be a massive team effort and it's basically going to be integrated into business as usual. So it's not going anywhere really. So yeah, so I'd like to think that we've learned a lot through the programs that we've been offering last year, and we'll continue working together as a united force to provide all the immunisation programs that I've presented here today. So that's that closes my presentation today. This final image is in recognition of all healthcare workers. Our LHD was represented by the very humble and well-respected Dan Kelly. He's an Aboriginal health practitioner based in Berowra. He travels the district, ensuring better access to health for Aboriginal individuals and communities. Once again, I congratulate you all on your role, your contribution to caring for your community, and the execution of the immunisation programs is proven with the impressive coverage rates that we've seen today. Thank you for your time today, and I hope you enjoy the rest of the conference. Thanks.
Thank you both, Priscilla and Belinda. A great presentation, short presentation from Priscilla. You did as promised. Thank you again, ladies, very much. It's just about time for morning tea. We're just waiting on the scones for you. So you do have a chance for a little bit of a natter before we bring out morning tea for you. Because Priscilla was so short, we've got a couple of minutes spare, as a matter of fact. But it is an opportunity, if you haven't already downloaded the Slido app, to join the Q&A in there and to make sure that you're ready for the quiz later on. An opportunity to do that now. We'll let you know when the scones are ready. If you do require a comfort break, there are restrooms through on my left and also to the rear as well. I hope there's a scone left for me. That's all I'm saying. Ladies and gentlemen, oh, there is. Thank you, Claire. Very nice work. Guard it with your life. Just about time to get back underway. Everyone enjoy morning tea. How were the scones? Now everyone has tested them for me. They're good. I just want to thank the great crew at the Ex-Services Club for taking care of us today as well. Thank you very much. Now, as we know all too well, in our neck of the woods and across the PHN region, tyranny of distance is often something that we need to overcome. However, while working remotely seemed to be a dream that was coming for a very long time, that was one thing that COVID-19 and lockdown certainly gave us, was a vast leap forward when it came to the ability of working remotely and joining webinars and dialing into the endless meetings that we've all been subjected to over the last couple of years. And this is how our next presenter is coming to us this morning. Katrina is a proud Barkindji woman from the New South Wales Far West who works with the National Indigenous Immunisation Network to promote communication between the National Immunisation Committee and those involved in providing immunisation services to Aboriginal and Torres Strait Islander people. To present on the coverage and timelines of vaccination for Aboriginal and Torres Strait Islander communities, please make welcome remotely to the National Centre for Immunisation Research and Surveillance, National Indigenous Immunisation Coordinator, Katrina Clark.
Thank you for that lovely introduction. Yes, that was quite a mouthful. So, yes, as Sandy said, I'm Katrina Clark. I'm a proud Barkindji woman from Far Western New South Wales. And before I start, I'd just like to acknowledge country as well. So I pay my respects. And acknowledge the traditional owners of the custodians of the land on which we're all meeting on today, and I pay my respects to your elders past and present. I also respect their culture, their knowledge, and their unbroken connection to country as well. And apologise for not being there in person. I did want to come out, but I thought if I went halfway home to Ivanhoe, I would more than likely continue the 6 hours drive. So I'm zooming in today from Newcastle on the wonderful land of the Awabakal people. So this is just some of the beautiful photos, personal photos that I've taken over the years. So this is the gorgeous Cobb Highway here heading into Ivanhoe, and this is me standing on Barkindji land in Broken Hill. And then some just beautiful pictures of Newcastle Beach down here. So what I thought I'll do today as well, I will be presenting a bit of an overview about the timeliness of vaccination and also highlighting the inequalities in disease burden, in particular meningococcal B for Aboriginal and Torres Strait Islander children, as well as just touching a little bit on the influenza and also on COVID-19. So what I'll be presenting today as well, it comes from these three reports. So unfortunately, I'm unable to show you any data from NC's latest 2016 to 2019. So this is the vaccine preventable disease in vaccination coverage for Aboriginal people. So this report will hopefully be released later this year as well. So as I said, unfortunately can't show you any of the data, but I can speak about it. So the national immunisation coverage for Aboriginal and Torres Strait Islander children, as of December 2021, while we have again exceeded the target of 95% coverage for Aboriginal and Torres Strait Islander children aged 5 years and over, it's also worth noting that our latest quarterly data for New South Wales period ending the 30th of December 2020, we have seen a decrease in all of our milestones. So that's unfortunately I'm unable to show you that data, but just to keep in mind that that data will be out as well, hopefully soon. And so we just really need to try and now concentrate on keeping those rates up. So just touching a little bit on that as well. So the 2020 NC's coverage report, it also highlighted that timeliness for Aboriginal and Torres Strait Islander children, it's still quite high, and it remains like a really persistent issue. So that report, the NC's report, that was released late in 2021. So I just now would like to chat a little bit more about these diseases. So again, sorry for the data overload on this one slide, but I thought I wanted to really highlight the timeliness issue on the three of these vaccines. So as you can see, for the second dose of the DTPA, only 82.9% of the Aboriginal cohort were vaccinated on time. So i.e., so this is 5 months of age. So even though the vaccines are due out 4 months, but when we do and calculate this, we consider them being on time. So it's 30 days after the vaccine is due. So that's out 5 months. So in comparison, so that's 92% of non-Indigenous children were vaccinated on time compared to the 82.9%. So as you can see, so that's a 10% delay or difference in Aboriginal and Torres Strait Islander kiddies receiving their second dose of the DTPA. And again, on this graph, this is the 13-valent pneumococcal vaccine. Again, you can see that it was only 82.9% compared, sorry, I can't really see, I think it was like 92%. So that's 82% compared to 92% of non-Indigenous children. So that's just, again, under 9.7% difference with Aboriginal and Torres Strait Islander kiddies not getting immunised on time. And then down the bottom as well, we can see the on-time immunisation. So that's for the MMR. So that's the first dose of the MMR. So on time, so again, it's like they're due at 12 months of age, but we allow for the 30 days. So there's only 67.7% of Aboriginal cohort or Aboriginal and Torres Strait Islander kiddies are getting their first dose of the MMR vaccine on time compared to, oh, where's this little slide? Compared to the 79.5% of non-Indigenous children. I just wanted to really highlight these three diseases because even though we, in the past that we do have great coverage results. It's just our timeliness. So that's the timeliness of our young bubbies being vaccinated on time. Because as we all know, Aboriginal and Torres Strait Islander kiddies, they, are more likely to be admitted to hospital if they, if they're not getting their immunisations on time. The Commonwealth is also, they've taken all of this into consideration, and they have now on the 25th or the 26th of April. So they have launched their childhood immunisation campaign. So that's to encourage childhood immunisation and especially the timeliness of vaccines. I know that they've encountered with NITV, so digital videos as well as social media, so Facebook and Indigenous radios. So hopefully, all of these activities now, hopefully they will, enhance this. Service providers as well as parents are really getting, our bubbies are vaccinated on time at a timely manner. The meningococcal bees, unfortunately, this is the only data that I have at the moment and can show. So I can also say from the serotype B invasive meningococcal notification rates for the 2006 to 2019 period, that they were really similar and broadly similar to the 2011-2019 period. And as you can see from this graph as well, like the disease disparity, so these are all the notifications. So by serotype B in Australia, you can see that, it's our 12 months kiddies are quite high, our 12 to 23 months. And then also it's our 14 to 10 to 14-year-olds, so Aboriginal and Torres Strait Islander people, so they're highlighted in the blue. So it's this disease disparity as well is a continued issue for Aboriginal and Torres Strait Islander people. Again, we know that particularly in New South Wales, that we have a 3-year catch-up program for Aboriginal and Torres Strait Islander children aged less than 2 years of age. So that's up until the 30th of June to 2023. So the burden of COVID, so we'll just chat a little bit about COVID now. So Aboriginal and Torres Strait Islander people, so that they have 2.5 to 5% higher rates of intensive care admissions or deaths from COVID compared to non-Indigenous people. This is really similar to other respiratory viruses as well, so such as the influenza. So therefore, it's really important that we recommend the booster shots for Aboriginal and Torres Strait Islander people. So this really protects, as we all know, it really protects against the most severe COVID disease. It also protects a lot against, it provides, I can't even speak, protection against long COVID as well. So the current COVID, well, this was the current COVID when advice when I developed these slides. So hopefully nothing else has changed since last week. So as we all know, like all children now from 5 to 11 are eligible and are recommended for the COVID-19 vaccination. Particularly, it's important amongst these children who are at high risk of severe illness from COVID. It's really including those kiddies living with the underlying medical health conditions as well. So the primary dose 1 and 2 is recommended for everyone. Primary dose 3, as we know, is people aged 5 and over. And then the booster dose currently it's not recommended for our 5 to 11s, and then again 12 to 15-year-olds. And then it's our winter boost that we really do need to recommend to people over 16 years of age, as well as our Aboriginal and Torres Strait Islander people aged over 50 years of age. Again, it's really important that all providers record all vaccinations, including influenza and COVID on the Australian Immunisation register. So now let's look at influenza vaccination coverage. So this slide is comparing the 2021 with the 2020 Aboriginal and Torres Strait Islander people. So during the COVID-19 pandemic, there has been like a reduction in circulation of the influenza virus. So lower levels of influenza coverage as well for Aboriginal and Torres Strait Islander people compared in 2021 compared to the 2020. However, with COVID-19 measures easing and a resurgence of influenza is expected this year as the borders open up and we get back to some kind of normality, this is really important. And this graph really highlights as well that we need to really recommend influenza for our Aboriginal and Torres Strait Islander communities. I can also say that the 2016 to 2019 period in the vaccination, in the Indigenous VPD report, the period in the 2016 to 2019, influenza was the largest responsibility of notifications and hospitalisation of any vaccine preventable diseases for Aboriginal and Torres Strait Islander people. So that's really, I suppose I really would like to highlight the importance of recommending as well as providing the influenza vaccine for all Aboriginal and Torres Strait Islander people aged 6 months and over. Oh, again, so this is the influenza advice. So as I said earlier, with the easing of the restrictions of COVID-19, this winter season, we will likely see a both increase in transmission of COVID virus as well as influenza. So it's really important, as I've been saying, like to really recommend and provide both COVID vaccine and influenza. So they both can be administered and given on the same day. So in summary, sorry, it's a quick snapshot, but in summary today, I really hope that I've highlighted, despite our successes in our vaccine coverage, there is still that disparity in a number of vaccine preventable disease. But however, there's still that delay in immunisation as well. So that timeliness of immunisation for Aboriginal and Torres Strait Islander children. So making sure that our Aboriginal and Torres Strait Islander kiddies receive vaccines on a timely manner is like, we need to really try and come up with some more new strategies. So that strategies, not just at the national level, but at state level, as well as that local level as well, to really make sure that keeping our babies and our most vulnerable kiddies out of hospital. So that's really making sure that our babies are immunised on time. So at a national level and a local level, so NCs have collaborated with the National Aboriginal and Torres Strait Islander organisation, so NACHO as well. And we've also came up with quite a lot of resources. So it's the Vaccination for Our Mob. Again, this report will be out later this year as well. So that's highlighting the disease disparity in the 2016-2019 period. And then we also have the Meningococcal B vaccination. So this is a guide for healthcare workers to really support that conversation with Aboriginal families, as well as having that conversation with non-Indigenous families. So this resource really came about as well because we were getting lots of comments from providers saying, how do we respond to our non-Indigenous families saying that meningococcal B vaccine is only funded for Aboriginal children. So this resource really highlights the reason why the meningococcal B vaccination is only funded for our Aboriginal children. It's because the risk down here, like our babies are almost 4 times admitted to hospital compared to non-Indigenous children. And then we've also updated the influenza vaccination during COVID pandemic as well. So this is another great resource for service providers as well, not to hand out, to give to Aboriginal and Torres Strait Islander families. So just highlighting those important reasons to why these vaccines are funded and should be provided to Aboriginal and Torres Strait Islander peoples. And that's it. Questions?
Firstly, I think a round of applause. I think everyone would agree for Katrina. And we do have a little bit of time for you for some Q&A. Bruna's on one roving microphone. I'll use the other. But if I could ask, if you do have a question to ask Katrina, that you raise your hand and wait till the microphone gets to you so everyone can hear your very important question. So are there any questions for Katrina? Oh, there has to be one.
I'm happy with that. That means I've covered everything, hopefully.
Well, one on the other side of the room, Bruna.
Hello. It was more of a general comment, really. I've just noticed the rates of immunisations has been impacted, especially in our facility, because we had major restrictions on visitors. So families weren't allowed to bring siblings. I was just wondering whether that's impacted other services, especially for our Aboriginal families where they mightn't have childcare facilities and mum brings the whole family when they come to immunisation appointments. So I've just found that as an ongoing problem.
And we just have, sorry, Katrina.
Oh no, I was going to say, I think we're hearing that across the country as well with all the restrictions, and that's one of the reasons as well, maybe for the low coverage now in immunisations. But hopefully now with all the restrictions, and we've seen it now in the data with the declining coverage rates. We're hoping now once the restrictions are open, just to really try and get those families back into services and get, the vaccines into arms.
Katrina, just one from the Zoom chat. Are these New South Wales or Western Far West stats?
So the national coverage, that's and then these are national coverage. So we've seen a national decline in all coverage, so across all Aboriginal and Torres Strait Islander milestones. That's at a national level.
Thank you for that. Thank you for that clarity. Are there any other questions for Katrina? Any more bids? Going once? Going twice? Well, I'd like you to join me in thanking very much for your time today from NCIRS, Katrina Clark. Thanks, Katrina. And with that, we might seamlessly go into our next speaker. Are we enjoying the day so far? I'll take that as a yes. So we do have we have time for one more presentation before lunch, which I don't know after those scones. Truth, I don't know if we'll need it. At Western New South Wales Primary Health Network, we really do enjoy the collaborative support of many talented experts, like we've already seen this morning, Priscilla, Belinda, and Katrina as well. It's a marvellous testament to their dedication. Our next presenter is another who seems ever ready to answer the call. Strangely ever ready to answer the call all the time. Every time we say there's an invitation, he's here. Nick leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic. at the Children's Hospital at Westmead. So to present a COVID-19 update, a seasonal influenza update, and a Japanese encephalitis and Q fever update as well, please welcome, I'll need a breath for this one, Staff Specialist, General Paediatrician, Associate Professor in the Discipline of Child and Adolescent Health at the University of Sydney, and Associate Director at the National Centre for Immunisation Research and Surveillance. Welcome, Nick Wood.
Thanks very much. And I've just worked out, I don't know how to move the slides forward. Is there? Hello, everyone. It's good to be back in person rather than in the Zooms and the webinars. So this will be fairly rapid next hour, because if we're going to cover COVID, flu, Japanese encephalitis and Q fever in an hour, it'll be pretty speedy. But I've got the slides that we can leave with you and you can have a look at afterwards. So, and hopefully we'll have some time for some questions. So we will talk to you a little bit about where we are with COVID, a little bit on the oral treatments. That's certainly not my area of expertise, but I'll just highlight a few issues there. The evolving and ever-changing COVID vaccine schedule, which is very hard to keep up with, some vaccine safety data, and then some of the questions that we get. This is the global story. I think what's important here is you can see that the bars are the actual cases, and then the line is the deaths. And you can sort of see, even though most recently, early part of this year, the first quarter, while cases have soared, deaths haven't really soared as much. So that just gets to the idea of Omicron being highly transmissible, but less deadly. And this is another example of it. This is UK data where you can sort of see the alpha peak, which is the early time, and then the blue line, which is the sort of the percentage of the alpha peak, which is the decoupling, essentially, that people are getting infected with Omicron, but they're not ending up in ICU or dying. This is the situation in Australia. Again, there was a peak towards last year, which we all experienced, and then the current story here with nearly 6 million cases. And as we now know recently, the case count is a little bit wobbly because not everyone registers their RAT or might register a false RAT, dare I say. So there's those sorts of issues. You've heard about the changes, and I'll talk a little bit at the end about whether the BA2 subvariant is any different to the BA1. And now there are a few more variants coming as part of the Omicron as well. So it is an evolving virus, and I'll show you something about that as well. I think the other thing to show here is that on the sort of, I've got a pointer on this one, but you can see up the 0 to sort of 30-year-old age group. They were the main cases, which is basically the people moving around the community and infecting each other, but less as we get older. So this is really just to touch on the disease and how severe it is. And you won't be able to see that from the back because I stood at the back and you can't read any of that writing. In fact, it's even hard from here to read it, but there are new treatments that are about. And so this is a little bit of a timeline. There's a couple of treatments there. There's Lagevrio and Paxlovid, and they've only been approved in the last little while. Now, we won't have time to go into it, but these are treatments, essentially antivirals to treat COVID. And again, you won't be able to read it from the back, which is why I think it's important we leave the slides with you. But the key thing with these antivirals is that they're quite strictly controlled as to who can get them. And you have to have a risk factor, and there's a list of risk factors there. And you have to have it ideally starting this treatment within 5 days of symptom onset, okay? And so that's the sort of key issues with those particular treatments. All right, so in terms of vaccines, this is where we're at a global level. Around about 2/3 of the population of the world have had at least one dose. Enormous number of doses. So when people say these are new vaccines, not really tested, well, that's sort of not quite right because we've given over 11 billion doses now. Australia is doing pretty well. at a world level, we still have issues with about 15% of people in low income countries only having had at least one dose. So there's that sort of disparity which we know about. This is the Australian data, and again, you can't read it at the back there, but basically what we're trying to highlight here is the 5 to 11s. You can see the orange bars are the proportion that have had 2 doses, and you can see that it's around about more than 90%, certainly more than 96% for those over the age of 30. But when we go down to the 5 to 11-year-olds, the coverage is pretty low. So 52% of 5 to 11s have had 1 dose, and about 30-odd% have had 2 doses. So there is that difference. It is confusing, and we now have community Pfizer adult, community Pfizer pediatric, Spikevax Moderna for use in adults and in kids, Nuvaxovid, which is the Novavax one, and the one that we don't really use much anymore is the AstraZeneca, the Vaxzevria. I think a couple of things to highlight is that all of these are 2-dose primary schedule, okay? And now, as of last week, the idea is the TARGI, although they recommended, in my view, too late, the interval between dose 1 and dose 2 is 8 weeks. Okay, now but that was already happening for 5 to 11-year-olds. Now, because there's so many different vaccines, that little poster, I'm not sure if you've seen it, it's often quite hard on the Commonwealth websites to find these things. They're sort of buried in different pages. But that poster is quite useful. Now, there is so many vaccines that there is potential for errors. But this is a little bit about Nuvaxovid. It's different to the Pfizer and the Moderna ones in that it's a protein-based, it's just a spike protein. It's like a traditional old school vaccine, okay? It's not like the genetic ones that Pfizer and Moderna are. It says minimum there, it should be minimum. You can do 8 weeks apart now, is what the TARGI is recommending. If you've had previous SARS-CoV-2 infection, you can have it, and no problems with giving it to immune suppressed people. And it can be used as a booster, although there's a preference for Pfizer, which I'll come to in a minute. So there are potential errors that can happen with these vaccines, okay? And we've had reports to Encephalitis of, oops, I accidentally gave the 10-year-old the adult dose. Oops, I accidentally gave the 20-year-old the pediatric dose. So that's that higher or lower than approved dose. Issues with the thawing and the expiry dates, which are quite complex. It has been a tricky period for all you guys out there in the provider land. So there's some of the errors that can happen. I think when you do get an error, obviously you have to tell the person that that has happened. There is some TARGI advice on the administration errors. See if you can review how it happened and obviously to stop it happening again. They do want that to be reported to New South Wales Health. And if it is possibly an invalid dose, then you might need to advise the heir. There's quite a nice link there to the MVEC, the Melbourne Vaccine Education Centre, which has a nice page on this. Okay, so for the kids, it's 2 doses, as I mentioned. 5 to 11s are Pfizer, 6 to 11s could be Moderna. We don't want to give a Moderna to a 5-year-old. Okay, it's not registered for that age group. 8 weeks between doses. There's probably a lower risk of myocarditis. So this is just again some useful documents there about the Pfizer and what to check. These are nice, useful posters that I'm sure you've probably all seen before. As I mentioned, Moderna is really 6 to 11s, can't be given for 5 to 6-year-olds. It is a 2-dose course. The 3rd dose can be given, and we'll show you about the 3rd dose and the booster doses in a minute. It can be given with other vaccines, although I'm not sure in practice whether that's really happening in pediatric land, whether you're giving, you know, DTP and Pfizer, etc. The idea is that if you're 11, you get the pediatric dose, and if 8 weeks have passed and you're now 12 and 1 month, you get the adult dose. Okay, that's the thinking. As I mentioned before, we have had reports of people getting that round the wrong way, but Immunologically is not a problem, okay? It still will work. They chose those doses based on what they did in the vaccine trials. And there's nothing magic that happens between an 11-year-old and a 12-year-old in an immune system, okay? So this is a really busy table, and I don't know whether have you seen this poster? Anyone seen this particular poster? It's a nice summary of what to do. And I think we'll talk a bit about the booster doses and then the winter booster dose, which is that sort of light blue on the side there. And there are only specific groups in the community that are recommended a winter booster. So if you're 25 or whatever, and you've got a severe immune suppression, you really by September of this year should have had 5 doses. Okay, so it's sort of a 5-dose, 4-dose, 3-dose, 2-dose. And that really depends on your age and your underlying medical conditions. Again, we won't be able to read this, but this is really the list of immune suppression conditions that would put you into those boxes to get the booster and the winter booster. And so things that people will say is, well, you know, how effective are these? Do I really need the booster? How safe is the booster? I've had natural infection. When can I get the next COVID vaccine? So in terms of answering the effectiveness, this is effectiveness for kids, adolescents, and it's a bit hard to see, but down the bottom there is the time after dose 1, and the dark little blobs are the Delta effectiveness, and the little light blobs are the Omicron effectiveness. And you can see overall that protection against Omicron is less than it is of Delta. So that's the first point. And Omicron now is the dominant strain. There's very little Delta around the world. So Omicron's sort of the only game in town, really. So we don't worry too much about Delta. So that, and you can see that over time, the little blobs start to go down, and that's showing that the effectiveness is waning, okay? So we know that in 5 to 11-year-olds, I said before, the coverage was not that high, and I'm interested to hear from you guys why you think that is. Is it people are just sick of vaccines? Is it because they want more safety data? Is it because the kids have already had COVID and they're not, wasn't too bad, therefore why should I get a vaccine against something that they've already had? Are they back at work and back in normal life? All those, it's probably a combination. So we'll be interested to hear from you guys what are the issues. And there are lots of strategies that have sort of been looked at state and Commonwealth level to try and increase the uptake. So this is the overall protection from in the yellow box is probably the easiest one to read. In those 12 to 18-year-olds, effectiveness against Omicron is not so good beyond 6 months. Okay, it does fall to about 30 to 40%. In the 5 to 11-year-olds, the effectiveness, which is only about 68%. So it's not a 90% effectiveness, okay? This is just showing that Omicron is really the show in town, and this is data from South Africa showing that essentially what they're seeing now is people have had Omicron and then a couple of months later getting Omicron again. So they're getting reinfected. Now, whether the booster dose will stop you getting reinfected, that's what we need to find out. So this is the schema of a booster, really. The red line is what you get from primary vaccination, and that's the antibody level. And it goes up and then it falls, and then you get your booster, and then that little red dotted line, which is designed to stop you getting infected again. As you can see, the little red dotted line, no one's quite sure how high it goes and how long it lasts. But Kagi has said that if you're over 16, you should get a Pfizer or Moderna, not using AstraZeneca anymore really for booster doses. Although if you've had a problem with an adverse event after the mRNA vaccines, you can have the AstraZeneca as a booster, or you can have the Nuvaxovid, the Novavax one as a booster. And then the timing of that is 3 months after. So this is going back to that slide there, and you can, hard to read, but that's when the boosters are timed for. How effective is it? This is data from the US, so from the UK. And what it's really showing is that the little hash lines are the Delta protection, so we don't really need to worry about them anymore, but the other non-dashed columns are the Omicron protection. And again, it shows Omicron is less protected than Delta. And with time afterwards, the protection wanes. So the other way to show that is this. So the little blobs, think of the little light grey blobs, that's after dose 2, and this is after the AstraZeneca vaccine, and the effectiveness is pretty much waning. This is after 2 doses of the Pfizer vaccine, the little grey circles and going down, so effectiveness is waning. When you get a booster, it goes back up. So this is real world data showing that it does actually stop you, when you've had your booster, from getting infected, but more importantly, it stops you getting into hospital. And the same thing here with the mRNA vaccines. So you can sort of see here that the little grey lines go down, you get your booster dose and it pops up, but you also get the hint with time that that's also waning. Does that make sense? So the booster just tops you up for a little bit, but unlike, unfortunately, an MMR booster, it doesn't last years. So that's our problem. We might have to be giving annual boosters. But boosting does reduce hospitalizations, which is really our main goal. I won't go into that one because it's too hard. So this is real world data out of Israel, and what they're looking at is a second booster. So it does get confusing for the average person. Which booster are you talking about? If I had this booster, I've now got to get a winter booster. But if you think of it in terms of doses, and this is actually deaths, and the blue line is the protection from deaths when you've had your second booster compared to those that have only had 1 booster. So Israel is showing that in people over the age of 60, this was the whole population, there was protection against death if you'd had a second booster. So that's really where we're thinking about the use of boosters. Same idea here. This is the protection against severe illness, the red after the booster, time since dose 4, which is the winter booster, you do get some protection against severe illness. And then the other point is that we're worried about the BA2 strain of Omicron. Is it still, does the vaccine still work? And this is data from the UK, which is showing that if we compare BA1 and BA2, the effectiveness, there's no real difference. So the BA2, which is now sort of becoming the dominant Omicron subvariant, the vaccine will still work. But now there's new strains, which I'll talk to in a minute. No boosters for 12 to 15-year-olds, okay, not yet. And that's for a range of reasons, is that the kids who do get infected, having had 2 doses, are in general not too sick. Lots and lots of information out there about booster doses. Decision aids, I don't know whether you've had a chance to look at the decision aids that are based at NCERS, quite useful. You can go on, it's an interactive thing. You can click on links and follow through, you know, which vaccine you choose. It gives you pros and cons, or what you see after vaccine compared to disease. Okay, so in terms of safety data, Ausvac safety, which I'm sure you'll all heard of, we've now had nearly 6.3 million Australians have filled out safety surveys for us, which is an enormous amount, which is fantastic. And they've looked at Novavax, AstraZeneca, Pfizer responses. This is the Moderna safety data. As you can see, the number of safety surveys from Moderna we've got is much less compared to Pfizer, which I'll show you in a minute. But what you can sort of see is that the light blue is first dose, green is second dose, and the dark blue is the booster dose. And like Pfizer, most of the side effects from this are after dose 2. But the dose 2 and the booster side effect profile is pretty much the same. So the thing on the side there is redness, fatigue, headache, muscle aches, etc., fever. So boosters of Moderna, similar sort of side effect profile to the second dose of Moderna. Pfizer, you can see there 2.1 million surveys after dose 1, 1.9 million after dose 2. Same sort of story. Dose 2, more side effects than dose 1. And the booster side effects is pretty similar to dose 2. So someone says, oh, look, I had shocking headache and muscle aches after dose 2. How am I going to be with the booster? You can say, well, you can probably pull up this if you want and show them, and then say to them, look, the booster is pretty similar to dose 2. It's not like it goes up, up, up. You know, it sort of plateaus off. So I think that's sort of a take-home message for people. The winter booster, we'll be doing surveillance on. We haven't got any data on that yet, but it's probably going to be similar to dose 2, dose 3. So that's sort of an easy message. New Vaxavid, the Novavax one, you can see not much in the way of people that we've got on the surveys, basically because it hasn't been used anywhere near as much as the other ones. Again, it's a little bit like the Pfizer and Moderna, a little bit more reactogenic with dose 2 than dose 1. And interestingly, around about 2 in 100 people report that they went to see the GP or emergency department in the first few days after, which is a little bit higher than the Pfizer. The little people there's only one person, whereas a bit more in New Vaxavid. Now, we're not quite sure why that is. Part of our thinking is perhaps that the people that are late to get these vaccines are the ones that were always going to get a reaction, if that makes sense. Hard to know. But children data, 130,000 kids. This is the 5 to 11s, 2 doses. In general, the kids' response is a little bit less than the adults. They seem to have less side effects than the adults. Now, whether that's because the kids tell their parents and the parents don't fill out the survey, or what, we're not sure. But that seems to be reflective of what was in the clinical trial. And then we've also got on the AusVac safety website other things like flu vaccine safety data, which I'll show to you in a later talk. You've probably all heard of the myocarditis story after the vaccines. This appears to be dominantly in males, and it appears to be mainly after dose 2, much less in common in females. We don't really know why that's happening. And you can see here that it's 12 to 17-year-olds, dose 2, that's his US data. This is the rate per million. Much higher than in the 5 to 11 males, and probably we can make this bigger, but the same thing in the TGA data. Okay, so this is all available publicly on the TGA website. In Australia, we're also finding it higher in males, higher in dose 2, and higher in Moderna compared to Pfizer. So that's sort of some take-home messages. I'll show you in the talk this after lunch how we manage these and what we've been doing with some of the follow-up for the long-term outcomes of these cases. So what can we expect in the future? Again, hard to see, but this is really just showing that unfortunately the vaccine is not like MMR or DTP. It doesn't last for years. We haven't had years to see it last, but because it's being actively looked at, we are seeing breakthrough infections. This is just trying to show to you that this is changes in the virus, okay? The steeper the line, the more rapid the virus changes. So compared to flu, the SARS-CoV-2, which is the virus causing COVID on the top left there, is the line steeper compared to the different flu strains. And that basically says that the virus is able to evolve faster than flu. And so this is the sort of thing which is the headline in the paper yesterday, BA4, 5, and another variant are here. And what we don't know is how infectious they are and how likely they are to break through the vaccine protection and how severe they are. So unfortunately, we're not really, although we have moved to it being a less severe virus variant now, it is continuing to change itself, okay? And the other important thing is that what this has possibly done is has impacted other routine programs, okay? So this is data from WHO and UNICEF, which is unfortunately showing that there has been a bit of a drop-off in the uptake of MMR and meningococcal and DTP vaccines at a global level. And this is data that you can see. This is up till December of the end of this year. This is national Australian data. And what's important is that the little dotted lines, that's the Indigenous population, whereas the solid lines is the all children. And you can get the sense there that the 1-year-old Indigenous kids, there's a concern, and it's reflected here, that the coverage rates at the 1-year-old Indigenous kids is starting to dip, okay? So that's an area we need to work on. And you can also see it in the 2-year-old kids as well, starting to dip just towards the end of last year. So that's something that has been taken actively at the Commonwealth and state level to try and understand why this is, and what we don't want it to keep going down, obviously. Yep. So the take-home messages, 2 doses, 8 weeks for 5 to 15-year-olds, Pfizer or Moderna. 3 doses for those that are immune suppressed, 5 to 15. 3 doses, sorry, 2 plus a booster for 18 to 64-year-olds. Again, Pfizer or Moderna is preferred for the booster. And then if you're over 65, you've got to live in those sort of areas, aged disability care facility, you do get the 2 primary, then booster 1, and then a winter booster, okay? If you've had SARS-CoV infection, that's sort of like a natural boost, okay? You can defer the vaccination for 3 months after that natural infection. And then, as I said, there's the 5-dose people. They're the ones that have got immune suppression. They're getting their 3 primary courses, their first booster, and then their winter booster. So I hope I haven't confused you all. And happy to take, and the other thing to finish off with on this particular section is that you can get COVID vaccines and flu vaccines on the same day. So if someone's over 65, they're coming in for their winter booster. I'll show you in another talk. There's some safety data and antibody data on getting both flu and COVID vaccines on the same day. The old story of having to wait 14 days between them is no longer an issue. So if they want both, they can have both. And there are certificates, so this is becoming an issue too. People wanting to travel overseas and being told by the country they're going to that need to have their booster, but they haven't had that booster, but they've had natural infection. What do we do in those sorts of situations? So I'll stop there and just see if there are any COVID questions. Yeah. Yeah, yeah.
Mainstream for the staff that give child and family, like childhood vaccinations as well. We're going to have struggle with the rates rurally. I don't know whether it's ever going to be a non-multi-dose vial in the future, and it's going to be mainstream if it's going to stay with us.
Yeah.
That's just my observation working.
Is that because it's not economical for them to give it, or just the extra training? Or
I don't. I think you hit the nail on the head with your first comment.
Yeah. Okay.
Yeah, and so then people have to travel, and they're already working, and the kids are in care. And
Yep.
Yep.
Yep. Yep.
If someone's had AstraZeneca as the primary course and booster because mRNA has been contraindicated. Is there any, with all things being equal with access, is there any preference for a further booster with AstraZeneca or Novavax?
Yeah, it's a good question. So you're saying they've had 2 AstraZenecas and they're getting their first booster, or they've had Astra 1, Astra 2, Astra 3, then, yeah. So look, I probably would go for Novavax than Nuvaxovid. There's no absolute right here. If they really want AstraZeneca, you can use it. But there might be some immune benefits to what we call the heterologous schedule, so mixing, vaccine A plus vaccine B, possibly. But if they said to, okay, can you show me I don't know how many people will do this, show me the number of studies or people that have had 3 Astras and a Novavax, and there is very little on that. So from a safety side. But there are some UK studies called the COV Boost study, where they purposely did mix and match schedules, but they didn't look at the 4th booster. Not yet. That's happening. But they looked at the 3rd booster, and it appeared that in general, the mixing and matching was slightly better for your immune response. Yep. Yep.
Second dose, and then when they had their 3rd dose, that they were really quite unwell. Some of them had 2 or 3 days off work.
Yep.
So then when some of them have been immunocompromised as well. So what advice would you have for them when they're going into having that 4th dose of, for a winter booster? Because some of them are actually really reluctant to go back to that again.
Yeah. Look, I think it sort of depends, like all good academic answers, it depends. If what the reaction was, if it was something like a myocarditis, a Guillain-Barré, something unusual that might have been linked to the vaccine, then that requires further study. If it was, I felt rotten, a headache, fatigue, muscle aches, I just couldn't get out of bed, there's that trade-off with getting natural COVID. So it's sort of a risk-benefit discussion for them. And then really, there's nothing we can do to prevent it. You can treat the symptoms, as you know, when you get those sorts of side effects. But like I said, in general, what we're hearing in AUSVAC safety level is that dose 2, dose 3 is pretty similar. We haven't got dose 3, dose 4 data yet, but likely to be similar. But there's always people like that, here was reaction 1, here's 2, here's 3. I'm worried about 4. And I think it gets down to what was the reaction. It was a clot, it was a GBS, etc. Then that needs further assessment. But if it was general fatigue, malaise, and particularly if they're immune suppressed, they just have to think about, do I go through that side effect again, or do I risk natural COVID? That's the sort of trade. There's no easy answer, I'm sorry. Yeah.
I just wanted to make a quick comment and also ask a question, if that's okay. Firstly, just wanted to echo those comments about the pediatric COVID vaccine, that multi-dose vials have actually made the rollout quite difficult for us because we've got to run them in clinics and it gets a bit tricky for people to come in with their onslaught of children. I think also in Orange, what happened, we saw locally that we had a massive outbreak of Omicron, basically just as we were starting to roll the vaccine out. And what that did was some kids had had 1 dose and then never turned up. We almost had a non-existent 2nd dose clinic because nobody turned up for the 2nd dose. And I think that's because of the enormous rate of COVID infection that we were seeing. And so many children caught it over that Christmas break that I think there's just been a poor uptake on that front. But yeah, I just want to echo the reality that I think opportunistic vaccination would be really helpful for us in GP settings, because I think parents would uptake it if their 4-year-old was already getting 1 jab in the left arm. We could potentially do it in the right, but it's just very difficult with multi-dose vials and very short expiries to pump out that volume of vaccination.
And there's a lot of wastage too.
100%, yeah. The second thing I just wanted to ask is if you have anything in the data about 3 doses of mRNA vaccine versus 2 AstraZenecas and say a Pfizer or Moderna as a third. What we've just had quite a few presentations to the clinic with people who have had 3 doses of, say, Pfizer. The third dose actually getting quite significant lymph node swelling. Is that something you've seen in the data by comparison? Yeah.
Absolutely. In fact, a couple of our clinicians at Encephalitis said that one had an apple under his arm.
Yeah.
So, it's quite well described, that lymphadenopathy.
Yep.
Again, the data from the UK COV boost study suggests antibody-wise, 3 Pfizers is certainly as good as 2 Astras and a Pfizer. So yes, lymph nodes are definitely reported after dose 3. Whether that happens again with dose 4, I can't answer you. It's possible. But it can last several weeks.
And finally, sorry, one last question. I've had a very busy few months. I attended an anaphylactic reaction to a Moderna vaccine. So I'm just wondering, with that person, I couldn't really, I'm looking at sort of all the things that are in the vaccine besides the actual protein. And I'm just wondering, is that person going to be safe to have a Pfizer booster in the future? Should we steer completely away from mRNA for them? What should we do?
So it's sort of most of the anaphylaxis that we've had, if you look on the NSIMS notification system, there's been a couple of hundred.
Yeah.
Now, when we look in detail at them, a lot of them are, which I'll show you in a talk after lunch, are that immunisation triggered stress response. So they oh, I can't breathe, that sort of thing, but not accompanied by hypotension, rash, tachycardia. They're not that. Although, and they do respond to adrenaline. Now, whether they just responded to, I've now got the safe medicine in me, I'm not quite sure. A lot of the people are describing vocal cord dysfunction, having trouble tightening their throat. And the Melburnians were quite clever. They actually, at the time that people were reporting that, they got the ENT doctor to come around and put a scope down in their mouth and looked at the vocal cord, and there was no swelling, but the vocal cord was sort of snapped shut like a stress response, vocal cord dysphonia sort of thing. So you're pretty brave, I reckon, in anaphylaxis to go and stick a tube down. But that's what the Melburnians were doing in the Monash Hospital. So to answer your question, if it's a true anaphylaxis,
I think it was. This person has really strange, she was asthmatic and she had very, a whole host of really significant adverse reactions to various other medicines. And I was basically trying to find a common denominator in there and sort of may have come across some sort of amine situation. So I think it was a genuine anaphylaxis. She didn't respond until the 3rd dose of adrenaline. And she had to have quite a significant amount of Ventolin, and she was very hypotensive as well. So
probably a platform change to go to Novavax.
Yeah, great. Okay, good to know. Thank you.
We might have to move on to the next. I think I've bitten off too much in terms of the amount of data I'm showing you, but did you want to ask your one? It's probably more useful for you to ask questions than for me to show a bunch of PowerPoints, because you all go.
Sorry, just quickly, I wanted to ask was that it's been told to me a couple of times that it is better for immunity to swap and change vaccines.
Sorry,
I'm just wondering if that's true.
So, is it? Yeah, that's sort of a funny one. I'll just get rid of all of these. Is it at the moment we're not sort of the party line is start with vaccine A, continue with vaccine A. Is that what you're saying? Is it better to mix and match them? Yeah. So, yeah. I think if we had more time and we weren't in a pandemic, we'd have the answers to those sorts of questions. We'd be able to, we also need disease to show that Schedule A, which is vaccine A followed by B followed by C, compared to vaccine A followed by F followed by G, we sort of need a bit of combination of disease in the community to see whether they work. But so it's all very, I suppose I'm getting at, we haven't planned the answers to the question that you want answered. Because of the pandemic, it's just get them in, make sure that we can protect people, stop them dying. essentially is what they're trying to
Get
do.
whatever you can get, really.
Yeah, pretty much. So, but in an ideal world, we would have, okay, country A, you use this schedule, country B, you use this schedule, same surveillance system, and we'll see which one works better. We just haven't had the time to do those sorts of studies.
Okay.
Yeah. So
no need to recommend that at this
I
point.
wouldn't be recommending, you know, you've had your 2 Pfizers, let's now give Novavax. We're not at that level of information. Yeah. Just can start, if you start with one, keep going with that one, unless there's been a side effect, really.
Yeah.
I might have to move on to the next talk. We're well behind. Flu. So I'll be quick with flu, because basically with flu, there hasn't been any last year and the year before. It's quite extraordinary. So this is flu notifications, and the bottom line is flu in 2021. That's the red line. It just didn't happen, to be honest. You can see that the slight, where is it? The sort of greenish line is 2019, which was an early year, and the sort of purpley line is 2020. So flu just wasn't around last year. But unfortunately, because flu wasn't around and COVID was, what we do know is that the coverage, which I think Katrina might have mentioned, was also in the over 65s, it was pretty much the same. Okay. But in the 5 to 14-year-olds, coverage in 2021 was 14%. It fell from 27% to 14%. And in the 6 months to 5-year-olds, coverage was 45% in 2020 and dropped to 25% in 2021. Now, I think everyone thought, well, there's no flu around, there's no need to get the vaccine. I want to get the COVID vaccine anyway. So this is flu vaccine safety data from last year, and I'll show you the flu safety data from this year. But last year, in the number of people that had the flu vaccines, about 230,000 people filled out surveys, and there really wasn't any side effects that were worrying compared to what we had seen in the past. This is 2022. We've got data on 5,500 people. You can sort of see that it's actually very hard to read now, look at it now, but basically the take-home message for you guys is if they say, how's the flu vaccine safety data this year? Early data, 5,500 people, it's looking okay, not any different to previous years. Yeah, what is interesting though is that other respiratory viruses are around. And the one to highlight probably, because I don't know about you, but it seems to be all of the university students have got a chronic cough at the moment. And I'm thinking it's the HMPV, the human metapneumovirus. That's the green one down the bottom left. And you can see that it's climbing up and it's sort of on the way up now. Other ones like paraflu, influenza, not much this year, although I think flu will come back. And people are talking about the flu COVID, the flu-rona combination as a nasty thing. Whether your body says, I've got COVID infection actively, I'm not going to let a second virus in, COVID's here, it's whether or not we'll see what happens. So the flu program for this year, we talked about the drop in coverage. I think the other important thing is because of that, it means that people that didn't get vaccines last year, but they got it the year before, they really haven't got any flu antibody in them at the moment. So they are quite naive to flu, because they haven't had natural flu either. So that's an important thing, particularly for the kids under the age of 2. In 2 years on this planet, they really haven't seen flu. They don't even had any natural flu immunity, okay? And also the pregnant women who we used to rely on getting flu, passing the antibody to the baby, they haven't seen flu. So that under 2-year-old age group is a little bit of a risky age. So flu comes back in a big way. Those kids haven't had any natural immunity. We talked about them being given on the same day. Over the age of 65, Fluad Quad is recommended. And from sort of now onwards, as you're all experiencing. If you did get that 2021 vaccine late last year, then you can still get the 22 one. Okay, lots of information which I won't go into. Hard to read this from the back, but this is the usual string of vaccines that are out there. The ticks indicating which ages you can have them. I won't go into that because you can't really see it from the end anyway. This is the data I was talking about. If people say, well, have they really studied flu and COVID vaccines when given together? Yes, they have. There's a couple of studies out there. You can take home these and have a look at these slides later on. But what they really want to do is when they do these combination studies, when they give you flu here and COVID here, they want to look at what's your side effect profile like, and does me giving you 2 active vaccines on the same day interfere with your antibody response to either the flu vaccine or the COVID. That's the idea of those sorts of studies. So usually what happens is you rock up, you get flu and COVID on day 1, and then you might come back 2 weeks later and get 2 placebos, or you get flu and a placebo, 2 weeks later, COVID and placebo. That's the way they sort of do them. Yep. And so they've done that, and the safety profile is the same when compared to the separate administration, and the antibody responses are the same. We talked about this before. You can get it with other vaccines. I think one of the things that probably is maybe something that you do get asked is, I don't know, you could tell me, I want flu, I want COVID, and I want the shingles vaccine on the same day. I don't know, does that happen? Whether that's being asked by people, I think probably it might be better to give flu and COVID and then wait a little bit to give the shingles one. It's probably how I would do that. And we talked about egg allergy before. If you're egg allergic, you can safely have any flu vaccines, even if you're egg anaphylactic. People who are traveling towards winter might want to get a top up before they go to the Northern Hemisphere. There's an approach to Guillain-Barré syndrome on the AUSVAC safety website if someone says I had that before. The other useful thing is this talking about immunisation website. You can have a look at that one. Lots of information. That's more based for the actual person, member of the public and the parent. Quite a useful little website. There's a provider one as well, which gives you tips on how to talk about vaccines to people. And lots of flu resources, which are all on the NCA's website and State Health Department, which are all pictures here that you can have a look at. So I'll stop there, and we've got to make sure we get to lunch on time before we go and talk about the next pandemic, Japanese encephalitis. Any flu questions? You're all sorted with flu? Yep. Yeah, good question. I meant to put that in the slide. Did you all hear the question? Look, there's the ATAGI advice says when recovered, pretty much. So if I've got COVID, I'm over my fever, my chills, and I'm back to normal, I'm back to work, I'm feeling okay, I think you get the flu vaccine then. Some people do get a lingering cough with the COVID. Now, you probably don't want to wait months for that cough to go, so you might sort of choose a time that suits the person. So in general, when they've made a recovery. Yep. Any other questions on? Yep.
Like chronic.
Yeah, so this yes is the answer, but it's not just AstraZeneca. Pfizer have reports coming through to the adverse event system of triggering a new onset autoimmune disease, thyroid problems, bowel problems, rheumatoid arthritis sort of problems, or if you've got an existing autoimmune condition, the vaccine has flared it. So yes, there have been reports about that. Trying to tease out the vaccine's contribution to it is tricky. Oh, it'd be, I don't know absolutely, but if I just looked at the notification data, which is sort of a bit of a guess, really, it'd be 1% or less probably. Yeah, yeah, very unlucky. But there have been definitely reports of, you know, thyroiditis, hepatitis, those sorts of things that never had before. But again, working out the vaccine's contribution to it is tricky to do. Yeah. We often look for many other causes. So Guillain-Barré, for example, is like a immune-mediated disease, and we have had reports of Guillain-Barré after both AstraZeneca and Pfizer. And usually that happens in the first 6 weeks after the vaccine. Yeah, anything. So basically, we don't really know what causes Guillain-Barré, but Guillain-Barré has been linked to Campylobacter gut infection. So some sort of infection, some sort of foreign antigen, your immune system just doesn't quite deal with it right, and it attacks yourself. So we just don't. It has been reported, yes. Yeah. So I'll just spend the last sort of 15 minutes on a quick gallop through Japanese encephalitis. If we, perfect. Any other questions on flu? No? Anything else? Well, yeah.
And the booster vaccine?
Yep. So that's happened?
Yes.
So you've unknowingly been brewing COVID, or you had a little bit of a tickle in your throat. You thought, oh, I better get that booster, and you go and get it. And then 3 days later, you test positive. Your body will deal with both natural and the vaccine. So you're not, we don't think that if you have both at the same time, that you're going to get worse COVID or a worse reaction. Does that make sense?
Coverage from the booster?
Yeah. You should still get coverage from. So the natural, I mean, again, the thing is, the natural infection will boost your immunity, and it'll probably give you a broader immunity. But people say, well, aren't I better to get the natural infection? And the answer to that is yes, if all you get is a bit of a cough and you don't get too sick with it. That's the way to go. But I can't tell you that if I give you COVID now, that you're going to have 3 weeks off work or 1 day of not feeling so well. That's the problem.
But the booster still works.
But the booster, it'll still give you some, and either natural infection will boost you and the vaccine will boost you. Yeah. So just when we thought we were over one pandemic, along comes JE. And I'm going to be interested in your local context and things, but this is just a quick clinical story of a 11-year-old boy, previously well, had a seizure, jerking movements of his arm and leg, went on to have a tonic-clonic seizure, and then he had this sort of problem with his staring and problem with his language. Won't go through all of that, but suffice to say, he went to hospital, had a whole range of testing done. His MRI of his brain showed this meningoencephalitis, EEG showed some seizures. So it was an encephalitis, there were seizures. In this particular case, his Japanese encephalitis serology was negative, but you can see that we looked for other sorts of flaviviruses, Brucella, Bartonella, and he was treated with antibiotics. Not that they did that much, but treated with antivirals and steroids. So Japanese encephalitis has been detected, which I'm sure you all have heard about, know about. This is work from one of the sort of, if you like a good Twitter, Cameron Webb at Mozzie Bites is very good. He's sort of Australia's expert on mosquitoes. And so it is a flaviborne virus, and it's associated with pigs and water birds, and pigs are an amplifier, and I'll explain that in a minute. most of the time, if you get infected with it, it's usually asymptomatic, but it can cause that encephalitis type picture. Okay. So the mosquitoes come from the birds usually. Mosquito bites the pig. Okay, the pig grows up more of the virus. Mosquito then goes back and bites the pig again, has a lot of virus in it. Okay, and then goes to bite human. So the pig is what they call an amplifier of it. Okay, pigs don't get too sick with it, but and as you know, we've had a lot of water around recently, so that's pretty good mosquito territory. This is the type. This is the key mosquito. Cameron says it much better than me, but Culex annulirostris is the one that does transmit this virus the best. There's another mosquito, which is that annoying one that you get in the middle of the night that goes near your head, the brown mosquito. That doesn't transmit it as much as this particular one, okay? It likes to feed on birds and pigs, but it only goes really 12 kilometres from where it's sort of based, okay? These don't fly from Bundaberg to Sydney. They're not long distance mosquitoes. The water birds, so we've had a lot of water, as we know, lots of flooding, and the above average rainfall is good for the mosquitoes, and that leads to these floodplains. The birds have also moved across from the north up in sort of Philippines area, and that's because of a favourable climatic conditions for them to move. What's probably important is that the temperature, mosquitoes don't like a low temperature. So as we go into winter, this will probably burn out, if that makes sense. However, having said that, it does become dormant in the mosquito, and then when the temperature rises again, the mosquitoes take off again. Unfortunately, it's sort of here to stay, and the reason for that is that it's in the piggeries, okay? I don't know whether did Priscilla talk to you about, did you talk, is it, whether there's much in the way up here or not? Yep. The key areas are Victoria, down in this sort of, can't quite see it there, Gippsland region, and in New South Wales around, again, you won't be able to read that from the back at all, but Wagga, Albury, Griffith, Mildura. Human cases have been confirmed, and it is in the piggeries. And the other big issue is the feral pigs. So we don't know much about how much, or at least I don't know much, but maybe public health knows, I'm sure, more than me. It probably will be, it's not just going to be biting, you know, domestic sort of cultivated pigs, it will be getting into the feral pigs. So unfortunately, it's here to stay. This is where we've had, it's new to Australia, but it has been a part of life in this part of the world for many years, and they get lots of cases, okay? Much more than we ever get. And importantly, less than 1% of infections do result in neurologic diseases. And you can, it's hard to see here, but this graph here, the top one shows Japanese encephalitis, and the red line is the incidence. So most of the time, the new onset cases are in the younger kids, okay? And the blue line is the seroprevalence. So that means we go out into the community, we take blood from people, which is what's been happening now with public health around parts of the state, taking blood from piggery workers and their families, looking whether they've had exposure to JE. As you get older, you have had exposure. This is when you live in those endemic regions. But less than 1% do get neurologic problems, like I showed you with that kid before with encephalitis, seizures. They can have this, this sort of stare, they have this mask-like stare that you can get from it. But then the outcome is, unfortunately, if you do get the encephalitis, you can end up with a nasty sort of chronic neurological problem. And unfortunately, you can die from it. So you can end up with ongoing seizures with some neurodisability. So it is a nasty condition if you do get the encephalitis part of it. In terms of prevention, obviously personal protection is important, trying to avoid getting bitten, wearing the clothing, etc., the repellent. Public health will be able to talk to you more about what they're trying to do at the piggery level, working with agriculture. But in terms of vaccines, I'll tell you a little bit. As of a few weeks ago, I'm sure this has been updated, there have been 37 cases, a mixture of New South Wales, Queensland, and 3 deaths, unfortunately. In terms of a response to it, the government is trying to buy extra vaccine. And I'll show you in a minute the groups that are recommended for that vaccine. CDNA, which is the Communicable Diseases Network of Australia, has a group which is working on ways to control this. So these are the groups of people that should get the vaccine. Those working or living close to piggeries, outdoor activities, particularly mosquito populations, travelling north to the endemic regions, and then the lab workers. Unfortunately, there's no specific treatment once you get infected. They've tried a range of different medicines, and there's nothing that really works brilliantly. So the best way is to avoid getting bitten, or if you're in those groups, to get vaccine. And there are 2 vaccines, Imajev and Jespect. There's a list of contraindications there, which we don't need to go through, and some of the precautions. And Imajev can be given from those over the age of 9 months. I think the key issue really is the supply of it and how controlled that is. There's a little bit of a concern about giving not so much an issue here, but if you wanted to get, for example, if you're traveling, the JE vaccine and the yellow fever vaccine, you're better to get that at the same time because they're 2 live vaccines. If not, you have to separate them by 4 weeks. But that's not really an issue for a local JE control. And you can have the Jespect, which is the inactivator one, at the same time as those ones. Lots of resources. So I don't know whether you want to quiz about JE or whether Priscilla wanted to add any more on JE. Yeah. Good question. At the moment, we don't think it's pretty effective. We don't think you need booster doses with it. I can't give you I can get back to you on the actual length of immunity in that one. Not sure. Any other? Yeah.
Tried to be, because he's a recreational fisherman and he also goes to a lot of remote places in New South Wales with his work, and he was declined because he didn't work in a piggery.
Yeah, I think that gets down to supply. Yeah.
So keep trying.
Would be my advice, keep trying. Yeah.
Thank you.
Yeah, but I think because they want to, it's a little bit like most at risk. Let's do them first. Next at risk, that sort of thing.
But it wasn't very clear because the practice he went to wouldn't even get it. They said they couldn't get it.
Yeah, yeah. I think they're until they get more doses, they're fairly tightly controlled, which is what you've experienced, which is reasonable.
Yeah, no, that's reasonable. But his work, I guess it's going to be. Is it going to be a problem in the flooded areas too? Are they going to try and get those people that are working in those
I think probably what will hopefully will happen is as we go into winter and temperatures dip, that this becomes less of an issue. Yeah.
Okay, thank you.
Any other JE ones? All right. And then the last little bit just on Q fever, which we've talked to you about before. This is sort of the background to Q fever, which I think is this bug called Coxiella burnetii, transmitted from like other zoonotic infections, of which COVID was one, is one, JE is one, Q fever is one. This is found transmitted from humans from cattle, sheep, goats, etc. It's airborne usually. Most people who have the Q fever are pretty much no or few symptoms, but if you do get sick, you usually have a severe flu-like illness, and there's this sort of 2 to 3 week period where you sort of incubating it, and then you get a flu-like illness. Unfortunately, you can get severe complications like hepatitis and pneumonitis. There is treatment for it, and usually you can have time, but there is this issue with long COVID, not long COVID, long Q fever or chronic fatigue. You can get chronic infections like an endocarditis. So that it can be quite nasty as a side effect of the Q fever infection. These are the groups of people that are high risk due to their occupation, and there's a big list there which I won't go through. And so these are because if you're at risk, these are the people recommended to get the Q fever vaccine. Other people that you might not have thought of who should think about it are family members of those high-risk occupations, people living near the high-risk industry, visitors to those high-risk industry, or those that are sort of the horticulturalists or gardeners in the environments, because it can be spread by, dust. And there's a story of one of the theories of a guy who mowed the lawns at a golf course was he was mowing over the kangaroo feces and aerosolizing them, and he inhaled it that way. So those sorts of things are possibly ways to infect it. The diagnosis is usually made by a blood test, serology. There's lots of different antibodies that is measured, and it's usually sent to a reference laboratory. Ideally, a couple of samples to look for a two-fold rise in antibody. The vaccine, as you know, is a single dose vaccine, but it's not just roll up and get the vaccine, unfortunately. There's a screening period for it. So you do have to have an antibody test, a blood test, and you have to have a skin test. And that's the pre-vaccination testing. And if you're negative on both of those, then a week later, you go to get the vaccine. Yep, you go and get it read and then get the vaccine. Those that have got egg allergy proteins should not be vaccinated. And the current rule at the moment is kids under the age of 15 should not be given that vaccine, or pregnant women. We've listed those there, particularly the screening test is the most important one. You need someone who's good at accurate at reading them, the skin test, to make sure it's negative. Because we don't really want to give you the vaccine if you've had natural Q fever. There is lots of training modules. This Australian College of Rural and Remote Medicine has a really good training module, which is worth having a look at. And then the Q fever register is how you can get registered the practice can get registered to give the vaccine. And then lots of resources there, which we'll leave you in the slide. So any Q fever questions? Yep. Yeah, it is. And we'll talk to you afterwards because we'd want to enroll kids into a trial.
Okay.
Where in my view, that's a group of kids where so when you look at notification, so Q fever is notifiable, and that means is if the lab finds a positive case, it gets notified to New South Wales Health, and so we can count them all. If you look at notifications in the under 10s, it's not very common. 13, 14s, it does step up, and then 15, 16 and older, it sort of goes up. So there is a jump up between that 13, 14 age group. Now the cutoff of 15 is purely historical. It's just that because the trials were done in the abattoir workers years ago, and probably the youngest abattoir worker was 16. And so they thought, oh, he's the youngest, we'll register it from that age group onwards. Again, nothing magic happens between a 13-year-old and a 16-year-old in terms of their immune system. So we've got a trial that we want to do where we enroll kids 10 to 14-year-olds to basically give them the vaccine. We've already done 10 kids who've had it, and it's all been fine. So talk to you afterwards. We're hoping to do that in not much point doing it in Sydney. We did it in Sydney because we wanted to do the pilot study, and in fact, even though we did it in Sydney, we were actually getting kids from Bega because they were more interested. So more use out in the regions. So we want to take the trial to this region, Tamworth region, Armidale region, and then also in southeastern Queensland. So we'll try and answer your exact question.
Just more on Q fever. Sorry, I know I've asked a question
Oh,
before.
yeah.
But I had a mum recently who was planning on going back to work as a shearer. And because it's good work for a couple of days and then you can go home and be with your baby, but she was taking her baby with her while she was shearing. And so the QV advice was don't take your baby, but then what does she do? Then she can't work. So yeah, it was just more pointing out that that's becoming more popular for women to go shearing. And that's a COVID problem as well, because we weren't allowed to travel. Shearers couldn't travel between states to shear.
Right.
So the women have picked up the work and taken their kids.
Okay. So there's a risk for the kids by being in that environment.
Yeah.
Any other? I know there's a lot of information, so we'll make the slides available and you can have a look at them, and happy to answer questions. You can email us or through Michelle.
Applause on cue. Well done. I don't even have to thank Nick, although I will be thanking him again later. And indeed, if you've got the Slido app, you can pose more Q&A questions in there too, because we will be having Nick, Priscilla and Belinda up here for you to really have a go at with your questions at the end of the day as well. So if you want to make sure that you don't forget any of your questions, you can pop it in the Q&A tab in that Slido app. And if you haven't done that already, you'll be able to get into the Slido chat just by scanning the QR code on your program. You've been so well behaved. Must be time for lunch. Well, we're going to try and do this in a slightly more orderly fashion than what we did with morning tea, but lunch is served in the back room and special dietary requirements are on the right. Please make use of the hand sanitizer if I can ask. The table's at the back of the room, the last row first. And there is food for everyone. And we've got lots of time for lunch. Oh, and if anyone was very, very impressed with the scones during morning tea, I know Shirlene from the PHN has been able to commandeer the recipe. So Shirlene, who will be heading around the room, hopefully with the camera again during lunchtime, if you'd like to get a happy snap as well, or indeed the recipe, Shirlene has that for those scones. We'll also be using the Slido app for the trivia a little later on as well that Priscilla and Belinda will be hosting for us. Now, we have had a few questions about the resources that our presenters have been talking about today. Just to let you know, the PHN's own Michelle Drulis will be sending out through your registered email for this event some electronic resources, including the updated cold chain breach notification, the AIR 42A COVID vax status reports, and also links to today's presentations as well. So they're all going to be available for you through, that'll be sent to you, provided to you through the email that you use to register for this event today. So they will be coming your way. So without further ado, to start our afternoon session covering whole of life vaccination, adverse events following immunisation, and an AusVac safety update, please welcome again Associate Professor Nick Wood.
Thanks very much. So in an attempt to avoid death by PowerPoint, I'll try and stop after each of these sections for, we can have interaction and ask questions or give comments. So I just basically, this sort of next talk will set up a scenario of I think we did this a few years ago. I can't remember which one we did it, but a whole of life sort of scenario, and we'll sort of pause after each sort of stage of life. But I think a useful thing you may or may not have heard about is the halo principle. So when you see someone, think of their health, their age, their lifestyle, and their occupation, and then that might guide you as to what vaccines they could or not want. We often, when we present to medical students, we often say, here's the schedule, and I'll show you a picture of it in a minute. It's a 6-week dose, 4 months, 6 months with a birth hepatitis B. And how is that made? Well, it obviously starts with the vaccine being made, the research on the vaccine, then the implications for policy, and then actually how do you roll it out? So there's a whole lot of things that go into why we have a 6-month, 4 month, 6, 12, 18, etc. schedule, which is not, it's similar to the UK schedule and similar to the US, but it's different to the Scandinavians. So they have a 3-month, 5-month, 11-month schedule. So it is slightly different. Some vaccines are funded and others aren't, which you all know. We want to fund those, particularly if they're at increased risk of VPD, which is a vaccine preventable disease, because of your age, your underlying medical condition, or your Aboriginal and Torres Strait Islander origin. They're obviously recommended for everyone if you want to protect yourselves or others from that VPD, even if they aren't funded. And the funding becomes an issue because then it's sort of an ethical thing. I really want this, but I can't afford it. And that's something that we won't go into. But ideally, you guys as providers should think about the HALO principle and talk to the patient and let them know about these are the vaccines that could be recommended for you at your age, at your health, your lifestyle, and your occupation. There's a brochure up the back which has this particular schedule. The good thing about it now is it actually goes beyond the school entry age and has adults on it as well, and has risk conditions. So it's quite a useful take-home leaflet. There have been some changes, although interestingly in the last year and a half, no real changes to the national immunisation program, really because of COVID. The pneumococcal thing we'll talk about in a little while. There was this old historical category A, category B. I don't know if you remember it. It was very confusing. They've tried to simplify that into a single list, which is, I think, much better. Meningococcal B we'll talk about, and again, I noticed there's some brochures up the back there, who it's funded for, and we'll talk you through that when we go through the scenarios. The other meningococcal ACWY is funded for those with specific risk groups as shown here. And then HIB is funded also for those over the age of 5. Most of the kids would have had it as part of the Infanrix Hexa, but beyond 5 years, if you've got asplenia or hyposplenia, you should get a HIB dose. Okay, so let's talk about some scenarios, and hopefully this will work. So this is 19-year-old Mary and the partner Tom. Tom's close to having his 20th birthday, and they're extraordinarily organised people, and they've come to your practice because they want to plan to have a family. And I don't know how many 19 or 20-year-olds would do this, but Mary's mum said that she might have to have some vaccines before conceiving, and neither Mary nor Tom or their families identify as Aboriginal and Torres Strait Islanders. So what do you think you would want to discuss with them? Yep, so previous vaccines. Did someone say don't get pregnant? Was it? Go and spend the next 5 years having fun or whatever. Yeah, so the previous vaccine history is probably the most important one. So previous vaccine history, if it's known, and I think then you've got to go onto the air, or again, they're extraordinarily organised. They've actually brought their blue book with them. The need doesn't exist. A need for the interval between the live vaccines and conceiving. So you want to stress that idea. And why the benefits of that through the placental antibody transfer. Thinking about the herd immunity for grandparents around the baby. And identifying are there any underlying health conditions that they might need additional vaccines, and then talk about the birth hepatitis B. So I hope you can read that at the back. But so Mary did have her childhood vaccine schedule, as did Tom, but Mary didn't have varicella vaccine and she doesn't recall having had it. Tom had chickenpox, so he didn't get the vaccine. Mary got the DTP in high school, but didn't get her HPV and a MenC. And Tom had DTP, but didn't have HPV or MenC as well. So this is a sort of catch-up schedule you would think about. Varicella for Mary, 2 doses. MenACWI and HPV, 3 doses. Varicella is the only one that you have to think about deferring pregnancy. You don't want to give it, obviously, while you're pregnant. Tom, MenACWI, his HPV, and because he is 19, as you know, there's free catch-up before you turn 20. Okay, so that's a sort of a little bit of a time-sensitive thing for Tom's side. And so there is a nice, there's this leaflet, which you can find on the web, but there's also quite a nice table on the NCEARS. I think I haven't put it here, but NCEARS, and I said to Michelle, we might send it around a table on or e-link on the NCEARS website, which talks about the funded and recommended but not funded vaccines. So that's the sort of, any questions with any of that? Yes, Tom did have Boostrix. So Tom had received Boostrix at school, so he's okay for Boostrix. It's a make-up scenario. Yeah. maybe he was extremely organised and he realised he hadn't had it, so he went and got it. Yeah. So I think the key point here is think about the interval between live vaccine and pregnancy. This 20-year-old catch-up free is important. Okay. So Mary's now, they work quickly, Mary. She's now with mum and she's pregnant and she's 12 weeks and she's well. Mary's mum questions you about why Mary needs to be immunised, as Mary's mum didn't get any vaccines when she was pregnant. And Mary's mum also mentions the need for the boost for whooping cough. What would you want to talk to Mary about? She's now pregnant, 12 weeks. She did get a varicella in. She's got her 2 doses in. Flu, yep. Flu, Boostrix, yep. And COVID, yep. Yep. So flu at any time during pregnancy. Pertussis, I think it also pretty much any time during pregnancy. There's a little bit of a desire to sort of give it mid-second to third trimester, only because it gives mum time to make antibody and then antibody to cross to baby. Does that make sense? There's not much point giving it to mum at 38 weeks gestation when baby's born at 39 weeks gestation. Just won't protect baby. Yep. And then the COVID vaccine. Now, ideally, she's already had them, but she may or may not have had them. So if she's already had them and she's due her booster, she can have the booster. Any questions with any of that? All good? We talked about the antibody transfer. Pregnancy can be nasty. Pregnancy can be nasty. Flu can be nasty for pregnant women. And whooping cough. Whooping cough is not nasty for pregnant women, but it's nasty for the babies. Yep. So that's the main reason. And the cocooning strategy is the booster for grandparents and those that visit. Yep, which you're all doing. Okay. This is a little bit of data, which I hope I'm not getting in trouble from, but I've nicked from Sonia Ennis. Pertussis uptake in 2020 was 79%, which is pretty good for pregnant women. Flu was 59%, okay? This shows you by LHD, and we haven't listed them. So if you're looking for Far West or Western, I don't know which one it is, to be honest. But you can see that what's good is they're going up, red to blue, yep. So that's good. That's flu coverage for pregnant women. Varies by LHD. This is pertussis coverage, pretty good. Yep. Some of them are going the other way, but most of them are getting better. So ideally, we'd like to be, you know, and I'm not sure how COVID in pregnancy has interrupted the flow of flu and pertussis. Be interested in your thoughts on that, but it's pretty good. I think in general, pregnant women feel that I'm going to take the pertussis. This could be completely wrong. Pregnant women feel I'm going to take pertussis vaccine because it's good for my baby. I think that's a bit of a driver. Flu, well, they've had flu when they weren't pregnant, and maybe flu was not so bad, but it can be nasty for a pregnant woman. Yep. Any questions with any of that? No, all good. Okay. So now we've got a different family. 6-week-old Kira and mum Sonia are new to your practice because they've moved from South Australia. Kira was 38 weeks gestation and no complications. She's only had the birth Hep B. They're Aboriginal and Torres Strait Islanders, identify as Aboriginal, sorry, and they live in New South Wales. So what should Kira get? Yeah, so her normal 6-week shots, Hexa, Rota, Pneumo, and Bexsero. You guys are all over it. So because Aboriginal and Torres Strait Islander, when people have an increased risk of VPDs, unfortunately, we do need to think about the Men-B program, which is Bexsero, you've all mentioned. Think about, importantly, that, as you know, Bexsero can cause fever. So the Panadol part of it, prophylactically. Household contacts is important. Influenza vaccine for mum and household contacts. Baby Kira can get the flu vaccine when she's 6 months of age. And because it's the first time she's getting it, she's supposed to get 2 doses. Yep. Anyone else in the family that we need to think about? Any other kids? Yep. Yeah. And I think we showed this before. So this is the coverage for the 1-year-old. And just to highlight again that we are worried a little bit about the dip in the Indigenous kids. And so there's work to being done. And you guys are all part of that to turn it around. Yep. In terms of Bexsero, so really it's the number and timing is a little bit dependent on when you start it. Okay. So if you started at 6 weeks to 5 months of age, and you don't have any medical risk conditions, so that's the second line there, you need 3 doses as part of that primary schedule. Yep. 6 to 11 months, same idea. More than 12 months, you get the 2 doses. This is all detailed in there, but that's just, I think if you walk out of here, if you're not used to giving Bexsero, one, think about Bexsero, then go and look up, okay, you're 7 months of age, I need this amount of doses. Yep. Prophylactic Panadol. Can it be given at the same time as other vaccines? Yeah, yeah. So you can give it and the other one. If you do get Bexo and Prevnar in the same leg, some data suggests that you're more likely to get a bit of a red swollen leg. So probably better to split them if you can. About 2.5 centimetre distance, depending on the size of the thigh. And as you know, we like to give it in the upper limb from 12 months of age, and it's really dependent on the deltoid size, obviously. Lots of consumer resources which are up the back there. So Men-B is recommended for all children, but not funded for all, but it is recommended and funded for Aboriginal and Torres Strait Islander kids under the age of 2. Okay. If you've got specific health conditions, like as listed here, then you also get it funded for. And in New South Wales, you've got to check the history in the air, particularly as this kid moved from South Australia, where it was part of their routine program for all kids. Yep. So you just check that, which I'm sure you all do. Lots of resources out there on meningococcal. We've got the links there for you. Okay, so Sonia went home and discussed the need to keep baby Kira protected. She's come back with the parents now. So this is the grandparents, 52 years of age. Do they need any vaccines? Any thoughts? So again, you want to look at their previous vaccine history, the halo idea, the health, the age, the lifestyle, the occupation. In general, well, as you get certainly over 75, your immunity is not as good. That's why you need booster doses of things like flu, shingles, pneumococcal, okay? So the other vaccines to think about is the flu vaccine. It's recommended and funded from all Aboriginal and Torres Strait Islander. The pneumococcal, also recommended and funded for Aboriginal and Torres Strait Islander people over the age of 50. ACWY&B if they're underlying health issues. HIB if you're underlying health issues. Occupational type things like Q fever. And then the shingles vax. So it's from 70 years of age, but you can, if you really want to, purchase the shingles from 50. Kira, who is an Aboriginal and Torres Strait Islander child, will get the 3 doses of Prevnar 2412 as part of the routine schedule. And because this is the the Aboriginal and Torres Strait Islander children living in this states. It's the routine schedule, 2, 4, 12 months. And then children with risk conditions or living in those other states actually get an extra dose, okay? They get 2, 4, 6, 12, and then Pneumovax. So that's not her story because she's not in those states. This is again detailed in the handbook, but these are sort of snippets from the handbook. Anyone aged over the age of 12 months who has an at-risk condition, and you can't read them at the back, I know, but these are some of the at-risk conditions for pneumococcal disease. You should, and if you're over 12 months, regardless of your previous pneumococcal history, so if, for example, you develop diabetes at the age of 15, okay, you should get a single dose of the Prevnar and then a 23-valent pneumococcal vaccine later on. That makes sense? Yep. If you're an Aboriginal and Torres Strait Islander adult without a risk condition, you're not going to remember all of this, I know, but I think the prompt or the message is, if you're working with it all the time, you will know it, but think about it as an extra dose or just tweak, do they need extra vaccines, and then go looking for the advice. So if you're over 50, you should get a Prevnar and then a Pneumovax, okay? Which is this particular grandparents. They're 52, they should get a Prevnar, 13-valent, and then get the 2 doses of Pneumovax. Okay, then non-Indigenous adults, it's at 70 years and they get a single dose of Prevnar 70. That's not this particular family, and that replaces the old Pneumovax, which was given at 65, okay? So that's that one, and I think we talk about, so this was the new table. The old table was this category A, category B, and it was so confusing that now there's this single table which is shown there, and you can look down the left-hand side for the medical risk condition, go across to the other column, and it'll tell you whether it's vaccine, yes or no, and funded, or yes or no. So people will ask, why do we move it from 65 to 70? Okay, why was there a change from 23-valent to Prevnar? The risk of bacteremia or the nasty pneumococcal pneumonia is higher from 70 years of age. So the thinking was that if we give it to you just before you're at the higher risk, that and it's a better vaccine, the 13-valent Prevnar, the conjugate vaccine is better than the 23-valent, you'd have better immunity to last you longer. So that was the idea behind it. That meant that if we gave it to you too early, it might wane and therefore not protect you when you got over the age of 70. That was the thinking. So the vaccination from the age of 70 would ensure that you had protection as you got into an older age group. And there's lots of evidence now that this 13-valent Prevnar vaccine works pretty well, particularly against nasty pneumococcal, which is the bacteremia or the pneumonia. Okay, so can you give it at the same time as the Zoster vaccine if you want to? Yeah. Shingrix is, as I said, can be given, but it's not on the program, not funded. And we'll talk about that in a little bit time. But you can give it at the same time. If you've already had 23-valent Prevnar and you've now turned 70, but you've not had that, can you get it? Yep, you can. So whether you, if say, for example, you had the Pneumovax when you were 65 and you're now 70, yes, you can go and get the Prevnar, okay? We'd like you to wait at least 12 months between when you had your Pneumovax and you get your Prevnar, okay? That's that one. So the key messages, it's on the schedule, which you all know, at 2, 4, 12 months. Additional doses for Aboriginal and Torres Strait Islander children in those states. That's a 2, 4, 6 plus a extra dose of the pneumococcal polysaccharide vaccine. Check the air and only 2 lifetime doses of Pneumovax. Any questions? Pneumococcal is not easy. There's lots of different pathways to go down. Your brain's probably hurting after lunch with all this pneumococcal. Yep. Yep, second Pneumovax. Yep, that's right. Yep, exactly. Yep. Aboriginal and Torres Strait Islander people from age of 50, 1 Prevnar and 2 Pneumovax. Overall, like we just talked about, 2 Pneumovaxes if you can. Over the age of 70, just a single Prevnar. It's very confusing. It's a shame. It's targeted because we want to target those at higher risk, so they need extra doses. Lots of pneumococcal resources as well. The spleen.org website's not bad if you've got some nice flowcharts on it. If you want, that's the one down the bottom there from I think it's Monash Alfred Health in Victoria. Lots of information here on the schedule for Aboriginal and Torres Strait Islanders. Again, look at those pictorials, they're quite useful. There's the catch-up calculator is now live. I don't know if anyone's used it and found it useful. Yeah, good, helpful. Yeah. So anyone else had a good experience with it? Yep, okay. And there's a Pneumo Smart tool, which is particularly for pneumococcal vaccines, and that's also been updated. So I don't know if anyone's had experience with that one as well. It's tailored for pneumococcal disease specific vaccine recommendations. So that's that little bit. There is a webinar coming up on shingles, which will be, what's today? It's next Thursday. So you can register on the NCEAR's website, talking about shingles, particularly the Zoster vaccine and the Shingrix. Any questions with any of that? Okay, hopefully that was useful. We won't go through any of that. So I might go to the next slide. Set. Yep. Should say that if the first talks when I on reflection, there was probably too much data, but if you feed back to Michelle and the PHN team and the public health team as well, specific topics, just let us know so we can get it right for the next people. Okay, so this talk will be a bit about adverse events, and so we'll start off with I think adverse events have had a lot of high profile in the last year because of the thrombosis, thrombocytopenia syndrome, the myocarditis. An AFI is essentially any adverse event that is, you know, if you get a vaccine and you get a red arm, it is an AFI, but it's sort of a side effect. Does that sort of make sense? Whereas if you get a vaccine and then the following day you have myocarditis, that's an AFI, unfavorable, unintended. So I think at the moment, if we don't really want you to report every small sore red arm, but if someone says, I got the vaccine and 3 days later I had Bell's palsy, yes, report that. Now this next slide shows you the reporting system for adverse events in Australia. And in my view, it's very, very complicated, but the grey is the person who has the adverse event. And I'll show you the New South Wales. So the vaccine's given to the person, right? They then come back to you guys and say, look, I think I've got something wrong with me after that vaccine. Could it be an AFI? And they seek you as the healthcare provider are ideally asked to notify that. Yep. And you notify that through to your public health unit. The public health unit will then find out more information, and they can also advise on vaccination and management. To do that, they'll also talk to Encephalitis, which is where we're based. So we'll hopefully guide you, and you can also talk directly to us, and we'll help guide you on, well, yes, this is an unusual reaction, or we thought about doing X or Y, or this is what it means for dose 2, okay? The public health units collate the clinical information. It goes on to the notifiable system, and then, which is NSIMS, and then off to the TGA, and then the TGA looks, all of that's all happening at a state level. And so that's this thing up here, you can see state and territory. So what I showed you here, all that, is that sort of first red box for state and territory. Similar sort of things happening in Victoria, in Queensland, in South Australia. So the TGA is getting all of these coming in from around the country. They then code it. If you really got energy, you can go and look them up on the public database called the DANE, and they do analysis and signal detection. So every week now, the TGA puts out a weekly safety report, which is relative to COVID vaccines, and you can just look on the TGA website and have a look at it. So that's the sort of passive surveillance system. In New South Wales as well, we have another really neat system called FREDS, which is an emergency department surveillance system. And it's running in the background, and it's designed for us being able to detect outbreaks of, say, gastro or pneumonia or respiratory infections. But they turned it on for COVID to look for things like chest pain and seizures. So they were also feeding into the system. Does that make sense? So that's the REDS, the passive system. Ausvac Safety, which you've all heard about, that's an active system. And that's where we go out to people who've had the vaccine and go looking for reactions. We survey you and say, did you have a reaction, yes or no? And that also feeds into the TGA. Then there's these hospital-based systems, which are down the bottom there. They're also scanning records. So PEDS is a hospital-based system of 8 paediatric hospitals across the country. And they're looking for cases of encephalitis, polio, etc., seizures, a thing called PIMS-TS. Have you heard of PIMS-TS, which is a post-infectious inflammatory syndrome after COVID? It's looking for that. The PREDICT is an ED system, EDs across the country. And then AFICAN is a clinic system as well. So Australia's got a pretty good active. So when people say, oh, no one's looking at vaccine safety in Australia, it's sort of rubbish because there's all of this happening in the background. Yep. So, and the other thing is when it gets to the ministry, what we then do, or the ministry will talk to, we have expert panels now that we can access to say, look, a case of Guillain-Barré has been reported. We'll pull together neurologists, public health people, and we'll have a discussion about that case. So that's another important bit that's happened since COVID. So that's the basic system that where your role is without you guys at the start reporting it, the rest of it doesn't work. Yep, makes sense. And that's how you report it. There is a form that's available on the New South Wales Health website. It's a TGA form. In my view, it's not a very good form. It's sort of very free text. People write, and what people tend to write on it is, you know, history of presenting illness. They write see discharge summary. And that's pretty useless because without the discharge summary, so it's not the best form. We can make improvements in that, but that's the form that's used. As I mentioned, serious adverse are generally rare. Some can be coincidental. So there's a you know, story of a seizure 4 days after a vaccine. Was that the vaccine? Was it just coincidental? Who knows? We do investigate those. And the thing to basically to minimize the risk of an adverse event is to use the pre-vaccination screening, okay? That helps identify whether that person has had a previous reaction, so you don't go on to give the same vaccine, or to work out whether they've got a disease, an underlying disease that tells them that they should not have the vaccine. Also look at the disease-specific chapters of the handbook. That's also useful. And then the correct injection. I'll show you a couple of adverse events. Tell the person there's a nice little fact sheet there which can explain to them about what to expect after a vaccine. So the most common one is the local injection site reactions. Come on about 24 to 48 hours. Usually might get to a 50-cent coin size, although they can go joint to joint. We have seen that. Most of the time they go away by day 5, day 7. So if the person knows, yeah, I got a bit of redness here, it's the arm where I had the needle, and they're happy, they're not too sick with it, haven't got a fever or anything else, they shouldn't cause fever, usually. They go within about 5 to 7 days. What we don't want them to do is to turn up to ED and be treated as cellulitis and be admitted for intravenous flu clocks, okay, which has happened. So that's, you can remind them about that. In terms of systemic adverse events, the commonest ones are fever, headache, lethargy. We have a list of the COVID ones we know. Allergic reactions, we talked about that a bit before. Anaphylaxis, which I'll show you in a bit, is not that common. There's a thing called, it should be not should injury, it's shoulder injury related, that's SERVA, and I'll show you that in a minute. Sounds a bit obvious, but fluids, rest, Panadol, and I think if they do get what we don't want, which we have seen, is someone who had a red sore arm, who put the arm in a sling and stayed like that for the next 5 days, and then they got a frozen shoulder. So then they needed steroid injections to undo the frozen shoulder. So you don't want to do that. This is SERVA. So SERVA is a rare complication when the vaccine's given too high, just below the acromion, okay? You can sort of see there, I don't know if you can make out the little X. When it's given too high, they're actually injecting it into a bursa underneath the bone here. Bursa doesn't like aluminium in it, and so you can get this SERVA. It's been reported after all the vaccines. So obviously the best way to avoid it is to give it in the right position. Anaphylaxis is very rare, usually happens within 15 minutes. And we'll talk to you a bit about, you can't read that, but the next slide hopefully will talk to you about what's now known as this acute stress response, or vasovagal. They both happen very shortly after the vaccine. If you get faint or vasovagal, you often get pale and a bit sweaty, okay? You might have some rapid breathing. You often have a slow pulse, yep. You can have some nausea and vomiting, and if you lie them down, it usually gets better. One of the things they found with the vocal cord thing that they did in Melbourne was they got people to take sips of water through a straw, and that helped to loosen the vocal cord constriction by the pharynx. The pharynx, so the pharynx went into a bit of spasm because they were anxious. Just having sips of water through a straw was helpful. But if on the other hand, you don't, if they've got stridor, wheeze, or rash, I wouldn't be giving them a straw. I'd be giving them adrenaline. That makes sense. So it is tricky, and in the heat of the battle, it's often hard to know exactly which one it is, particularly if the person's saying, "I can't breathe, my throat's really tight." You're not going to. You're better to just treat it as anaphylaxis. Okay, does that make sense? They don't. What I suppose I'm getting at, after the event, we can think about it, but in the heat of the battle, if someone's sick in front of you, they're pale, they're having trouble breathing, so I just treat them. That's what you do. Obviously, it's adrenaline. You can repeat it, and you know that there's a different dose by the age. So the Immunisation Specialist Service, this has now been going for 7 years. We've moved to an email-based service now. We think, although we still can take phone calls, but during COVID, we were getting 100, 200 calls a day, and we just couldn't keep up with it. The benefit for us for doing the email is that we can ask more questions easily, but we can also attach documents and links to information that you can have a look at. We can obviously give you guys advice about a reaction, but about should I have the vaccine, yes or no? This person's got this particular disease. What other vaccines do they need? Is it safe? We do have a specialist clinic where we can see kids, and we now have links to allergy specialists. To your point earlier about there's not many allergy specialists, unfortunately, in the regions, but we can offer telehealth. So there's people in Newcastle that can probably reach out. We're building a bit of a network of allergy specialists, but something to work on from our side. And then there's vaccination for kids and adolescents who it can be difficult to immunise. So there's the email for our service. We think we're pretty receptive, but let us know if we're not. And as I said, the thing that we often get asked about is it safe to co-administer? Can I give the vaccine earlier than is on the national program? And what are the extra doses needed for immune suppressed people? I thought I'd just update you on the myocarditis story, and then a little bit on this rare, which you may or may not have heard about, but to be alert but not alarmed. So you've all heard about TTS, because that was the story last year. TTS stands for thrombosis and thrombocytopenia syndrome. It was this rare condition that happened after AstraZeneca predominantly. Have there been a couple of reports after Pfizer? Yes, but mainly AstraZeneca. Not quite sure exactly why it happened. No longer really an issue because no one's getting AstraZeneca. This has scared the receipt of it. But if someone wants a booster dose of AstraZeneca, just to be aware that it's a risk, but although it's low, most of these were after dose 1 and not after booster doses. And they can present with clotting and low platelets, and the clotting can be pretty much anywhere in the body. But why it was found was that the clots they were getting were in the head, which is an unusual spot, in the cerebral venous sinus, which is an unusual spot to get the clot. So they were presenting with headache, blurred vision. If you got a big clot in your lung, you'd have shortness of breath. You may have had a DVT, so a clot in your leg. And some people were having, because of the low platelets, they were having bruising on their skin. It usually happened in the first month after that dose. But and there is lots of documents now about how to manage it, and we really haven't seen any cases reported now for several months. Any questions on this one? TTS? No? Okay. So myocarditis is the other one that's been hitting the airwaves. Like I said before, it's usually males, it's usually dose 2, and it's usually the mRNA vaccines. There are now guidelines out there about the clinicians on how to manage them if they see one. And, you know, physical exam, blood tests, ECG, and a cardiac MRI is important. And then obviously to be reported. This is the sort of cardiac MRI that we find. And when you look at these, you always look for the arrow. And the arrow is pointing to the little white area there. And that's what's known as late gadolinium enhancement. And that means there's areas of inflammation in the heart muscle. So that's what they look for when they do an MRI scan, this late gadolinium enhancement. So it's just showing that something is happening in the heart to show it's inflamed. Myocarditis has always existed, usually in association with the virus. Why after this particular mRNA vaccine, we don't really know. But it's also been reported after AstraZeneca vaccine as well, and after Novavax vaccine. So the biology of it is not quite clear. There's lots of guidance on future doses. So there's TAGI has a statement. The bottom line is if it's a proper myocarditis, so ECG changes, high blood troponin, and if you can get a cardiac MRI, then those people need to be talked to a cardiologist about the second dose. If it's a pericarditis, which is an inflammation of the lining of the heart, then the flow chart gives you a way to manage those as well. So why this is sort of interesting is that people, it is a new side effect, new adverse event. And so we really need to understand this more, particularly as mRNA vaccines are going to be the way of the future. So there's mRNA vaccines that will be built for flu, for respiratory syncytial virus, for whooping cough. So if it's something to do with the mRNA that's causing this side effect, we need to understand lots more about why it happens and what are the outcomes for these people who do get it, which is rare. Like I said, the rate, you may or may not think it's rare, but the rate in males, sort of 17 to 20, after dose 2 is in the order of 1 in 10,000. So it's not that rare, but it is happening. So in order to do that, the US have been following up these people, and we're also doing the same in Australia. So when it gets, there's also the important point as to why the notification is so important, because once it's in the notification system, we then go and follow them up to see what's happening over time. This is the US data, and they've got 360 myocarditis patients, and you can see that when they followed them up at the 3-month mark, in the blue is the people that said, no, I'm all good, no chest pain, no shortness of breath, no palpitations, no fatigue. So that's good. Most people are recovering pretty much from this. They're not having ongoing symptoms. You can see also that the bulk of people do have a normal echo, they have a normal ECG, but what's slightly, important, and we need to find out more, is that some people still have an abnormal cardiac MRI, okay? So we need to understand what that means as well. People are also, the other important thing we're doing is following, well, this is US are doing that, and we're also doing it. We're looking at their quality of life, and it has had an impact on people. They do report extra anxiety, which is understandable. That's the green line. So some anxiety down the track. So I think what's important for you guys, I do and I don't like giving the vaccine safety talks because you don't want to walk out of here being scared. But it is a rare side effect. We know, we don't quite understand why. Males, second dose, nearly all of them recover completely. They might have some underlying cardiac changes on the MRI, but what that means is not quite clear. So any questions with any of the cardiac myocarditis stuff? Yeah. Yeah, it's a good question. So how long after the vaccine do they have symptoms? It's usually in the first week. So sort of day 3, day 4, chest pain, palpitations, shortness of breath are the commonest sort of itis type symptoms. And they might only last a few days. And usually if you go to ED with those sorts of symptoms, they'll do a chest X-ray, an ECG, a blood test. And on basis of that, probably say, yes, it could be the myocarditis. Take some Nurofen or sometimes some colchicine to dampen down the inflammation. People don't like colchicine because it gives them diarrhea, but that's the usual treatment, and then it disappears. Yeah. So most people recover within sort of 4 or 5 days of the symptoms. Yeah. Any other myocarditis questions? Just if you weren't sort of worried enough, this came out just on the 22nd of April, and this is extraordinarily rare. And I bring it up in case you've heard about it, which you probably haven't, but there's a very rare genetic deficiency in those that are of Western Polynesian heritage, okay? So it's very unique and boutique, but there's a link if you have this genetic deficiency with an immune system problem. And that means if you get a live infection, like a measles or a virus, measles virus infection, you get very, very sick. There have been a few case reports of people with this particular genetic condition who got very sick after the MMR vaccine. So I just bring it up. A, you're aware of the alert. What that means for your routine practice is probably not much, but just in case someone says, oh, there's this gene problem that causes you to get really sick after MMR. That's what that's about. I won't go into any detail with that. And then the last little bit is, which we've talked about before, is really the flu vaccine safety, Osvac safety. This is some of the local side effects, the usual sorts of things, some fatigue, some headache, some sore arm. Osvac Safety also does the National Immunisation Program safety surveillance. So we continue to look at, Hexa and MMR and that sort of thing. So we were reporting on that. Quite useful website if you want to do some allergy training is the ASCIA website, ASCIA, that's really good. There's a refresher course on anaphylaxis management. Lots of information in the handbook and in the New South Wales Health webpage as well. That was it from me for that section. Hopefully we've got time for, I think now we're going into a whole series of questions. So anything on vaccine safety you want to ask? Yep.
Is there a treatment for TTS if it does happen?
Yeah, so yes, there is. So Australia has actually been sort of leading the world in this area a bit. So the key treatment is IVIG, so immunoglobulin, plus some steroids. And we've had a few deaths. Now these were people, unfortunately, that presented late. But we haven't had any deaths from TTS for many months. So there's lots of recognition at a community level and at provider level, and there's now good treatment. So and I think also when, as I don't know what you guys are experiencing, but I don't think AstraZeneca's been given much. Is there a no for that one? Yeah. So yes, there is a treatment. Yeah. COVID. Yeah. The question was, is there an association between an episode of shingles and COVID vaccines? Have we had reports of shingles after COVID vaccines? Yes. Yeah. Again, whether or not it's causal, no, nothing. It's what happens is they all get reported to the TGA, and then they do some fancy epi analysis to see is it more than normal. They also talk to the international regulators like the FDA and the EMA, which is the European equivalent. They all meet every month and discuss, I've seen X or Y, what's your rate showing? So just because it's reported doesn't mean it's caused by, but yes, there have been reports of shingles, reports of Bell's palsy as well. This could be any time. The reports that we've had have been up to the sort of 6-week mark. Yeah. The Bell's palsy, we've looked at those cases. Interestingly, when we go and question people that have had Bell's palsy after dose 1, they've gone on to have dose 2 and it's been fine. They just got over their Bell's palsy. So you know, Bell's palsy again happened all the time before vaccines. And we can show you a slide next time when we get all the data, but you can see the number of reports when a vaccine program starts just goes right up and then it just tails away as people get less likely to report it. Any other safety questions?
We did have a question from online, Nick, just with some clarity around the gap between flu and COVID vaccines.
The flu disease or flu vaccine?
The flu vaccine.
Yeah. So you can give it at the same time, or if you do want to separate it, I'd probably wait a week. The COVID vaccine side effects, as you may or may not experience personally, are often in the first 2 or 3 days. So, you know, if you're going to separate it, I'd just wait a week because you should be over any COVID vaccine reaction by a week. But you can do it on the same day. Any other safety? Yeah.
To have their little one immunised, one immunisation at a time because of leaky gut syndrome, because the dad experienced that. So I'm just wondering what the latest research is around. Is there any relationship between immunisations and leaky gut syndrome?
Yeah, I don't think we believe there is. There's nothing new I'm aware of. So this gets back to the old autism question. That was the vaccine did something to your gut that let toxins in from the gut to the brain, the bloodstream took the toxins to your brain and you got autism. That was the sort of hypothesis. There's nothing I'm seeing that supports that happening. I suppose at an individual level, if they want to say, look, we want to wait till he's 15 months or 16 months, you can do that, but you just run the risk of that longer period of being not protected. Yeah. What, MMR and varicella or all of them? Yeah. So we had a discussion about this actually locally the other day. I think philosophically, I don't have a problem with that. If they're motivated and they say, look, I want to have MMR, I want to design my schedule, tailor-made schedule. I want to have, Preventable on this date, and then I'll come back in a week's time and have MMR. I think you can do that if you're happy to do it. There's a sort of a few rules about we can't give MMR and then chickenpox a week later. We don't want to do that. I think if you're going to split them up, it's obviously extra work for the parents, extra trips, all that. A bit annoying for you guys to have to see them on several occasions. So I think it's, immunologically, it's okay. There are a few immunologic rules that you want to check. As you know, if you get MMR, you'll get fever and rash 5 to 10 days later. So if you give MMR and then you wait 6 days and you give Preventable and lo and behold, they get a fever and a rash, you won't know was it the MMR or the Preventable that did it. So there's a sort of a few things like that to explain. If they're really motivated and that's the only way you'll get a vaccine into them, go for it. That's sort of a practical approach, a pragmatic approach, really. But what the other thing we had discussion about, which I don't really support, is taking Hexa and splitting Hexa up, giving a DTP, and then a week later giving a HIB and then a week later giving a polio, and then a week later giving a Hep B. That to me doesn't make sense. But well, some people want to do that, but I don't, to me, and I point out to them that, because often they say, oh, it's the toxins, doctor, it's the horrible toxins in the vaccines. And they say, we want to split them up. And then I say, okay, you can do that, but Hexa's got this amount of aluminium in it. DTP's got aluminium, polio's got aluminium, Hep B's got aluminium, Hib's got aluminium. If you split them up, you're giving 4 times the amount of aluminium. Do you want to do that? And that sort of stuff. And they go, yeah. So that bit I don't think is scientifically makes sense. And there's also a child-friendly issue. That kid could get 1 needle as opposed to 4. So we don't encourage that. But the tailor-made splitting up in time is reasonable, I think, but extra work for you, extra work for the family. Any other safety? Yep.
People are stupid. I read it on Facebook, and,
Hello.
but there's been no link, right? Because I'd be like, well, no, not that I've read and not that I know of. There's no link to it, but also the vaccine hasn't been around for 10 years, so.
That's a good, I think you answered that well. So yeah, we can't, I mean, this is the thing that sort of irritates me in some sense with people says there's no long-term safety. Okay, yeah, okay, there is no long-term safety, but you're in the middle of a pandemic. We're not going to wait 10 years time to tell you what it was like. So that, and there is a nice fact sheet on NCEARS about fertility. And there's lots of studies there about the COVID vaccines and which I should, that's good. Next, take a note, next talk, we'll put that one in. These are what they did. They went to extraordinary lengths. They actually took sperm counts, gave a vaccine, and then took sperm counts thereafter from males to see was there any change. No change, nothing. They also looked at women falling, ability of women to fall pregnant. These studies have all been done. Maybe they're not publicly available but they do exist. Yeah. Yeah. Yeah.
There just must not have been anything reliable at the time.
And I think the other thing that people are concerned about is that these genetic vaccines will get into our body and they'll become incorporated in our system. And they don't do that. So the mRNA code, which is just the code for the body to make the spike protein, gets broken down. So and the spike protein itself also only exists for a small period in the body, enough for our body to recognize it as a protein to make antibody. Because you don't, once you get natural COVID, you don't have the COVID protein from natural virus for decades either. Your body breaks it down. So I think the easiest way to answer the genetic thing is to say that, well, when you get natural virus, the virus also has the code. It doesn't hang around in your body forever. So that's the simplest way to answer those questions. Any other safety ones? Are there other things you're hearing at the front lines, that murmurings? No. Okay.
On that note, Nick, thank you once again. There'll be another chance to ask Nick more questions very soon. People are stupid. That's going to be my main takeaway from today. Let's hope not, though, because you've been asking some questions. Now we're going to ask you some questions. You've got a couple of minutes, if you haven't already, to set up the Slido app. And I'm going to ask Priscilla and Belinda to come back to the lectern, because we've got some questions for you. From who? Got a bit of a trivia quiz that's happening for you, and winners will be grinners, I can tell you this much. So we've got a quiz that's been adapted from the WHO's vaccination quiz. Priscilla, aren't you hosting the quiz? You're co-hosting with Belinda and Michelle. We spoke about this earlier, I swear. I'll just shout at people, Priscilla. That's all you need to do. That's okay. Oh, didn't you get told?
No.
Surprise!
Here we go.
How's everyone going with the Slido apps? Have you been able to find the quiz tab?
And that's all, it should be fine. But I thought Michelle would have it. Oh.
Come on down, Michelle.
She's going.
At least we'll know what to do tomorrow, right?
Oh, exactly.
Oh,
Yeah,
okay.
this is like
Just roll with it. Just roll with it.
you're not doing this.
Did Eric put it up?
Oh.
No, I don't. That's right. And that's what
Yeah. Can you come back?
We're on the same page.
He's not going anywhere, is he?
No, it's still got
Oh, cool.
Bruno, she's over there. She's going to be controlled. I'll just check if you didn't want us to read them out. I was going to say, do we need to read the questions?
I think that was the idea.
Well, you've got a very good PA.
Yeah, you're got a bit of speaking voice with me. I hear myself back and it's like, oh, who is that? Ricky, whiny person.
I avoid this.
I can chuck on my far west course. I don't actually do that.
Oh, I should probably.
It's got my list, it's got 27 films, so it's not all screen, it's not all. It's just parents. They like the child.
The question on the screen, but we think it'd be nice if somebody did. So who would like to read the question as well?
Why else are they here?
To look beautiful. We're working.
Oh, yeah, yeah.
Yeah,
Apart from
that's
that, what functional purpose are they serving?
I'm over the age of that.
So go one for one.
Yeah, that's it. We'll work it. We worked out this morning, so they're saying.
Sorry? Oh, have we started? After a seamless transition, get ready to win some fabulous prizes. And we are going to redo the first question. So if we've upset you already, we do apologize profusely. But the first question will be going again. So everyone gets a freebie on the first one if you've had a practice. And if you didn't, oh, sorry. Are we ready to roll? Well, then without further ado, please welcome back Priscilla and Belinda.
There's a prize. And it's individual. So has everyone logged in or done your thing individually? Rather than, or are you as tables?
Table.
Oh, I think we might have to just change the rules as we're going.
Showing up the table might take some time. When do you want to get out?
Anyway.
And
so
we don't know what the
Friday
prize is, but there is a prize, a winner, prize for the winner. Can we have a prize for the most creative name?
Oh God, take
It's-
that down.
The prize will be coffee with Belinda and I for the most creative name. Oh, 3 prizes. Okay.
All right, let's get rid of that. Here we go. Question 1.
Question 1. What is who? A famous? Oh, do you want me to read out all the options? Who? Who is who? What is who? Who is who?
Who is who?
Where's it gone? Oh,
Hang on, we've got to stop. Go back. Who's pressing button? Is that you?
whom is who? That's probably what it should be, grammatically correct.
I haven't seen the whole package. Video to watch and then the questions.
I didn't.
If you could see viruses, you'd know. They're all around. Viruses, bacteria, and other germs. Where we are, they are. Where we go, they go. And life is too precious to let a virus or disease so easily preventable get in the way of moments of joy and delight. Of a first kiss, a first step, a first goal, a brilliant joke, a brilliant hug, an early start, a late night laugh. Maybe that's the point, to live every moment. Vaccines work to enable long life for all.
Hopefully you got the first question right, because that was the answer there. You can see viruses with the naked eye. Yay or nay?
How are we going?
Oh, gosh.
Oh,
Are we
slow
going
it
that
down.
fast?
Look, it's automatic. I'm not pressing any button. Did it work?
Okay.
Done? Will we go to the next question?
Do we have some super competitive people out there? Go on.
Oh, here we go. It's working. Here we go. All right. So that's our responses up there. Oh, well done. Well done. Yay. We're working correctly. Oh. All right, here we go. Today's vaccines help prevent more than how many life-threatening diseases? 5, 10, 15, or 20?
10 seconds to go. Okay, now we're on fire. 5, 4, 3, 2.
Time's up. Oh, what's the answer? What happened there? Wait for the answer. That's the answers from the crew. The answer is 20. Yeah, the answer was 20. Here we go, question.
Okay, the first vaccine, the smallpox vaccine, was invented in, if you listened to me this morning, you'd know the answer to this one, 1796. Oh, we're out. God, I've got to talk quickly.
Yep.
I need a coffee.
Everybody was listening.
Some of you weren't listening. 2021. Did someone answer 2021? Seriously.
Yes, they did.
Who answered 2021? nice one, Claire. 17. Well done.
Oh no, next question.
Oh.
The smallpox vaccine helped smallpox be a completely eradicated human disease. True or false? Everyone just bashed that answer in before I even got the question out. Is it working for everyone? Oh, we've gone back.
We may be experiencing some technical problems.
Everything's fine.
It's
Just go with it. It's a pandemic.
yeah, we are not on mute. I probably should be on mute.
Yep, we've done that one.
Are you able to see it on your feet, on your phones, on your things? God Lord. Can you see the next question on your phones? Not yet, right.
Oh, there we go.
Which of the following illness cannot be prevented by a vaccine? The common cold, measles, influenza, cholera. We've got 6 seconds, 5, 2, 1. Last one. Oh, good work. I think someone's out there just doing random.
Just mucking us up. Yeah, that's right. It's been quoted before. We won't be the first.
Next question.
Next question, please. The human papillomavirus or vaccine can prevent infection with the virus that causes 70% of cervical cancer cases. True or false?
Nice work.
Yes.
Okay, next. Oh no, that's the same question. Oh, I've got sweaty palms reading these out. So I don't know how you're all going. Well done. I hope I didn't get one that I can't pronounce whatever's in it. Okay. Next question. What works with our body's natural defences to build protection from getting sick? Vaccines, cold and flu medication, chicken soup.
See?
I do make a good chicken soup. And when I had COVID, I felt much better. Well done.
No, that's the
Oh no, that's not the right one. Don't worry about that.
We'll have to have a little show on ready for tomorrow, so we can
Be prepared.
vaccines.
Oh,
Yay.
chicken soup. Well done, whoever did that.
Chicken soup. Had to
It
have
does
both.
taste good. Okay. Next question.
Righto. I'm on slide. I be kind.
Yes.
Next. Every year, how many people get sick from flu? 1 million, 10 million, 1 billion, 5 billion. I think it's a world.
Okay. That's a nice split amongst 10 million, 1 billion and 5 billion, with the correct answer being 1 billion. Nice work, whoever got that.
35%
Well
of the
done.
crowd.
Yeah. All right, next question. I feel like we're losing some of you. Just remember, you're not on mute. This is a live audience. Okay, how often should you get vaccinated with flu? Just once in a lifetime, every year, every month, every 10 years?
Well done, well done. I think Slido's the 1% myself.
Well, there's someone just doing it randomly. Okay. Congratulations. Next question.
During the COVID-19 pandemic, it is particularly important for people from which target groups to get their flu vaccination? Pregnant women, healthcare workers, older adults, people with chronic medical conditions. Was there an all of the above option there?
Or all of the above?
Yeah, or all of the above. We got cut off. Oh. 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 Well done, everybody. Look at that.
Nice.
No one missed that one.
Thank goodness for that. Next question. Do COVID vaccines protect against flu? Yay or nay?
Well done. Can't trick this crowd.
6 to go.
I was going to say, not many to go now. You've been very patient. How often does global influenza surveillance and response system update the composition of vaccines to match circulating viruses? Annually or twice a year?
Quick, isn't it?
Oh, quarterly. There's more options. So a bit of a mixed response. And twice a year is the correct answer. That tricked a few people. Something like.
Well, that stumped a few of you. You got it. Well done. Okay, vaccinations help to reduce the severity of flu, reduce the chances of complications and death, reduce societal burden due to flu, or all of the above. I want to know what's happening. Oh,
There's someone later, Nate.
what's happening down on that back table? All of the
All
above.
of the above has got a hot answer, and that's correct.
Nice work.
Oh,
You're up.
When did Australia officially become polio free? 1970, 1980, 1990, or 2000?
I reckon there's a few in the room that'll know the answer to this. The answer is
Oh,
2000. Oh. Well, that one stumped a few.
That almost sort out the winners and grinners.
Okay, who's considered the founder of vaccinology? Florence, Louis, Edward, or John? Leonard. This one might stump a few too. Interesting. With the correct answer being Ed got it. I think that table that's laughing down the back of it. Yes, I'm looking at you.
All right, we're nearly at the end. 2 to go. Which famous Australian nurse trained at Broken Hill Base Hospital? Faith Thomas, Vivian Bullwinkle, Maud Booney, Elizabeth Blackburn.
Oh, almost half are going with Vivian. Well done. Nice work. Okay, this is the last question. Are we ready? Oh, silence. Oh. What date is International Nurses Day? 12th of April, 21 April, 12 May, 21 May. I think this was given away this morning too, because I mucked it up. 12th of May. Well done. Nice work, everyone. Who gets to announce the winner? Who's feeling confident?
Who's top 3?
Oh,
genius. Number 1, anonymous.
Okay, we need anonymous to step forward. Who's anonymous?
So anonymous will have it on their phone.
Are you anonymous, standing back there? Well done. Woohoo! What's Anonymous's real name? Simone. Well done, Simone. Okay, Gabby. Come on down. Oh, you better do one.
It's okay. You can have it.
This is terrible.
It's your inner
Yeah. I didn't know whether to go with Price is Right or
and you do the microphone.
Gabby, where are you?
She's hiding. Is she on
Don't be
home?
shy.
Is she at home? She's at home. Oh, it's a virtual.
Gabby, well done. Okay. Okay. All right. Sarah Thorncraft.
There she is.
Nice work, Sarah. Oh, we've got to get prizes because they all tied. Have we got? Oh, timed. Oh, well, Catherine, you've beaten Melissa by 0.04 of a second. Nice work. Catherine, come on down. Where are you? I thought that group down the back that are laughing, I've got to find out what the jokes were. Yeah, it's you guys. What are you doing? Oh, is there a Melissa in the room? Oh my God. Well done, everyone. Hopefully you learned something from the quiz. Oh, right. Have a seat.
Yes, have a seat. Did I jinx all that when I said people are stupid? Wasn't that seamless? It was wonderful fun. I was laughing. Now, congratulations to our winners. Now, we are running incredibly ahead of schedule. I know you'll be heartbroken to hear that, won't you? We do still have... Talking to the MC halfway through his sentence, and he knows exactly what she's saying. What? Okay. So also in the Slido app, you will find what we've got displayed up on the screen at the moment, what nursing means to you. These are some messages that we're going to be not only using for our own reinforcement of why we do what we do, but also in the lead up to International Nurses Day on the anniversary of Florence's birthday on Thursday next week. So you'll be able to input your own ideas into that section in the Slido app as well. Now, do we still have Nick with us?
I hope so.
There he is. Nick, if you'd like to rejoin us at the front, please, because now we have had quite a few questions come through via the Slido app here and online on the chat as well. And we're going to open up the floor to questions for all three of our guests today. And if I'm sure you, like me, would like to thank them all again, Priscilla, Belinda, and Nick, who have been just superb for us today. The problem is we only have so many of those mics. You will have to stand up to answer the questions. If you do have a question, please raise your hand, because there are people online that would also like to hear what the question is as well as other people in the room, because it can be a bit difficult if you're on the first couple of tables and facing this way. And Katie, you've got a few questions for the trio from online as well. And if you do have a question, Brenda and I will be roaming the room with the microphones. If you'd like to raise your hand and wait for the microphone to arrive.
So while we're waiting for some hands to go up, one of the most popular questions on Slido has been, is there any talk of developing an influenza and COVID combination vaccine?
Yes is the answer. So Novavax has working, it's a strange term, new Vaxavid, but they're working on a combined flu COVID protein-based vaccine. I think they're hoping to trial it possibly later this year. So yes, it's coming. The other thing that's coming is the variant-specific vaccines. So there's Omicron variant mRNA vaccine, which is in trial. Melbourne has there's lots of new vaccines. I think we probably should have showed you, but there's about, I don't know, another 60 vaccines in development around the world. And there's Melbourne itself has got a spike protein vaccine and another mRNA vaccine they're developing. So there's locally made ones. But yes, a combination flu COVID is in development.
Still no questions on the floor?
No questions. Okay, I'll go to the next most voted for question. What's the minimal interval between COVID vax and other vaccines if they're not given on the same day? For example, COVID and Zostavax. Do I answer this? I apologize.
No, that's okay. No, I think it's probably worth. There's there's an absence of studies on this, to be completely honest. So if someone to say, show me the studies that have given flu and COVID separated by a week, by 2 weeks, there's not many studies, as you'd expect, because we're sort of getting through the pandemic. But in general, the COVID vaccines, none of them are live vaccines. So there's not that usual rule. Remember with MMR and chickenpox, we like to have them on the same day or split them up by 4 weeks. There's not that sort of rule. It's all about, will they work as well? Do we reduce the immune response? And are there safety concerns? And the couple of studies out there with flu and COVID on the same day. No safety concerns and antibody responses are all right. In general, I think you probably want to wait maybe a week so that they get over the side effects of the first one before you give the second one. Now that's also an easy to say, but it's also logistically, you know, if someone was saying, look, I'm going to Europe in August and I'm only passing through this town once. I want to get both of them on the same day, but I'm a bit worried about side effects. I just give flu and COVID on the same day. That sort of pragmatic logistics comes into it as well. But there's no real, it's all about the side effects. But the truth of it is we don't have hundreds of studies that have looked at concomitant vaccines. You know, for example, Preventable and COVID vaccines, Zoster and COVID vaccines. They're coming, but they're just not here yet. So sort of based on first principles, we've given concomitant vaccines in the past. There's no thinking that there's going to be any major difference, but so that's, and if you're going to split them up, maybe wait a week between them. That's sort of off the cuff thoughts on that one. There's something else I was going to say, but I've just forgotten.
So this one might be for Priscilla and Belinda. Are health staff eligible for a winter dose? COVID winter dose? Do you want to jump up? Not really, sorry.
I've been asked that question a couple of times for staff health purposes, but at the moment, I could be wrong. Everything changes quite rapidly in this space, but the second booster still has some guidelines. So 50 years and over for the ATSI population, so our Aboriginal Torres Strait Islanders, and over 65 for the general population or people with immunocompromised conditions are eligible for that second booster at this point. I suppose we can only hope and wait and see. I'm sure it will probably become not maybe mandatory, but maybe recommended for healthcare workers. And I suppose it's the eligibility timeframe too that comes into play. We're probably coming into that timeframe now, so we're becoming acutely aware of that potential need. So I'd say there'll be some more information, but at this stage, no.
I think you've just answered the next question, which is, do you think health professionals will be needing a fourth dose as mandatory? So we don't know yet, but possibly. Yep. Okay. The next question is, will the meningococcal B vaccine be implemented into the childhood vaccination scheme or be subsidised for non-Aboriginal vulnerable clients?
Possibly the answer. To get onto the national program, they're supposed to go through the cost benefit, the PBAC process. Now that's sort of to be funded. That sort of all went out the playbook when COVID vaccines came on, because none of them went through that health benefit analysis. But that's what the theory is, that they're supposed to go into that. And they have tried before. The company has taken it to PBAC submission, and it didn't quite make the cost benefit cutoff for all population. It did for subgroups, but not for all. So they might go back once they sort of rejig the numbers, look at the hospitalizations, etc. But they're just, to be honest, there hasn't been a lot of meningococcal disease around, so it's going to be hard to make that cost benefit argument.
While we're on meningococcal, are we able to offer catch-up program for meningococcal vaccine in school-aged children that have missed out during lockdowns? Belinda, to the microphone.
Talk about trying to pass the buck. Yeah. So yeah, the school vaccination program is still just what it is. It's year 7 Boostrix and HPV, and then year 10 the meningococcal. So there's no talk of putting that meninge vaccine into the school vaccination program.
Okay.
I got one from the floor.
Oh, a hand up. Let's go with that.
I've got another question for Belinda. because the rates in children between 5 and 12 are so low, are they thinking about putting that in the school-based program?
At this stage, Michelle, that is very unlikely. You know, we did do a trial of trying to introduce COVID vaccines into the school space, but it actually undermined the long-standing confidence in the school vaccination field. So it was quickly removed. Parents didn't really want us to be sneakily vaccinating their children against COVID-19, and that was the general consensus. So to preserve the school vaccination program as it is, there's no COVID vaccine in that space. But watch that space, I suppose. But at this point, no, it's unlikely COVID-19 will be offered there.
Did you want to follow that up?
No.
Okay, no worries.
Oh, sorry. I have another question for Nick. As far as I understand, you shouldn't have an anaesthetic within a week of having COVID vax. Is it the same for like the shingles vax, because it's a live vaccine? Is it the same rule, or is it longer from when you have the vax to when you can have an anaesthetic for a procedure?
Yeah, funny you mentioned that, because I think I heard that last year that was it's a bit of a myth, really, that you should not have a vaccine after you've had the COVID vaccine, an anaesthetic after you've had the, yeah. So I don't think the College of Anaesthetists have advised.
I feel like it might, because I thought it was fine, but the anaesthetist I was working with checked it on one of their pages that they look at. And yeah, the recommendation was a week, but also under their discretion.
Yeah, I'll have a look on our INSEADs, because I think we did answer that in one of our FAQs. I'll take that one and get back to you. But I certainly wouldn't be delaying any emergency anaesthetic, you know, after you've had it. But an elective one, again, I can't see why you would not be able to.
Yeah.
First principles. I vaguely remember it being out there as a concern. But so the other answer your question about other vaccines, there's nothing I'm aware of to say that you should not have. We often give vaccines to kids who under anaesthetic, because they're there and they're having a blood test done, and we give them a vaccine at the same time.
Oh, that is good.
So we often do, not often, we sometimes do that.
Cool.
Particularly for kids with, you know, who, you know, parents are quite keen, or they're had a tetanus-prone injury and they're going to surgery to have it cleaned out. We often say, "Can you give us a tetanus shot at the same time?" So they do that. Yeah, but I'll find out about your particular comment, because I did hear that, but and I'll get back to you guys.
Nick, on the anaesthetic day surgery website, they recommend the anaesthetists are recommending it. It's not an NCS one or anything like that, but they're saying it themselves as we've adopted the following best practice guidelines. So it's them, not.
It may be that, you know, if you had a COVID vaccine and then 3 days later you had a reaction, but then you're having an anaesthetic, was it the anaesthetic or the operation that caused the side effect, or the vaccine? Maybe it's that, but I'm not aware of any sort of indication that it's dampens your immune response or anything like that. But I'll have a look. I do remember that issue, and I think I dismissed it, but I'll go back and have a look. Yeah.
There's quite a few questions here online. Can you give prophylactic Nurofen to kids instead of Panadol before and after Bexsero immunisation?
You can. I mean, the purpose of it really is to dampen down the fever. Just have to check the age of Nurofen and the kid, you know, the eligibility. We don't like to give Nurofen to sort of under 1-year-olds. You can, if you really want to.
Okay, next question is, can we give carers of immunocompromised a 4th booster, even if they are not immunocompromised themselves?
Not according to the recommendations, but I don't know. Do you guys want to comment on
Well,
that?
yeah, that's about it. It'll be at the liberty of the GP.
Yeah, yeah.
Okay. Next question. Someone had a second dose of Pfizer 10 months ago. Is it okay to have a booster now? Yes, yes, it is. Wonderful. If you had Guillain-Barré before, is it safe to have a flu vaccine?
Yeah, so that fact sheet I think I showed you, it talks about if it's natural Guillain-Barré, yes, it's safe to have a flu shot. If you got the flu vaccine and then within 42 days you had Guillain-Barré, then there's a potential rare association between flu vaccine and Guillain-Barré. In those cases, it's worth talking to someone about it. But for the average Guillain-Barré syndrome, yes, you can have the flu vaccine. Yep. Does that sort of make sense?
This is just back to COVID. A 17-year-old developed thrombocytopenia post-second dose. Can he take a booster dose? His platelet is down to 21 and he's on steroids now.
So which did they say which vaccine it was?
No, it doesn't say.
So if it was, so we have had reports of thrombocytopenia without thrombosis after AstraZeneca vaccine. Does that make sense? So people that have come in with low platelets but not yet had the clot. And that has been reported both in Australia and internationally. And it could be that the actual sort of, maybe the platelets dropped and they presented before they got the clot, if that makes sense. So the thrombosis and thrombocytopenia sort of go together, that the thrombosis causes the thrombocytopenia, but at the same time, there's a thing called, well, the hematologists have recognized this, I think they're calling it the thrombocytopenia, there's another name for it, but thrombocytopenia without thrombosis. In that, if it's after AstraZeneca, then yes, definitely talk to your hematologist because you probably won't want to have another AstraZeneca. You would change platforms. If it's after Pfizer, you'd think you want to investigate a bit more as to exactly was there another reason for it? Have they done it before? So it's just, I'm dodging the answer because you just need more information, to be honest. But if they're on steroids and it's coming up, I probably would wait till the platelet count had normalized before I gave it, would be my other thought. Yeah.
That Guillain-Barré, I don't know how to say that, I'm sorry. Would you give a booster COVID shot after Guillain-Barré?
So if they've had, again, it's sort of usually the Guillain-Barré that we think is potentially vaccine linked, is usually in the first 42 days after the vaccine. So if you had 2 of your Pfizers last year and you got, I don't know, Guillain-Barré in January, February, and that was more than 42 days after, we often think that's not related to the vaccine and therefore you could have a booster dose of Pfizer. But if it was timing within 6 weeks of a dose, then it's important to either talk to the immunisation service or to your treating neurologist, just to understand. In all of the Guillain-Barré cases that get reported in New South Wales, we collect detailed clinical information on them and we actually take them all to a panel of 3 neurologists and we discuss each case with them and they give us a likelihood of yes, it is Guillain-Barré or no, it's not. So we've got a pretty good handle now of the Guillain-Barré cases that we've had reported of which are real ones and which aren't. Because they can all, it's a tricky neurological condition. It can look like other things. So again, a little bit more information, but it depends when the timing was and was it really a true diagnosis. So always phone a friend, I think, if either get them to talk to neurologists or the vaccine service.
Wonderful, thank you. And is there any restrictions to receiving the influenza vaccine after testing positive to COVID?
There's no restrictions. I think it's just you're probably better to get when you've recovered from your COVID. So, you know, wait a couple of weeks till you're over it and then get your flu shot. Would be my thoughts on that one, but there's no restrictions really. No mandate, government restriction.
Okay. Are there any questions we haven't covered that people want to raise their hands about? Or that I've missed? What is the difference between the two shingles vaccines?
The biggest difference is that the Zostavax is alive attenuated and the Shingrix is inactivated. So the better advantage of the Shingrix one is we can give that to immune suppressed people. That's the biggest difference. So that's why there's a bit of a push or a desire to have that as the NIP vaccine. It's probably slightly superior in terms of effectiveness as well. So that's the biggest difference. Don't give, that's why the pre-vaccination checklist is really important. If any hint of an immune suppression, no to Zostavax. We don't want to give that because we have unfortunately had a few cases where it has been given, and it sets off a cascade of nervousness, anxiety for both clinician and for patient. And then they have to have, some people, if they're severe enough, have to go on prophylactic valacyclovir, might have to have swabs down the track. So, yeah, just pre-vaccination checklist, pregnancy, yes or no, immune suppression, yes or no. They're the key ones.
Wonderful. Yeah. Thank you. There's a couple here that might be for Priscilla and Belinda. Do we know why nurse immunisers in New South Wales are unable to administer Zoster? Or Nick? I'm not sure. Is that true? I'm not sure. Yeah.
Oh, in like an independent, but you can do it at the GP practice. Yeah. I suppose it just hasn't been approved in the therapeutic drugs.
Okay.
Not a nurse initiated. Yeah, so it's probably not a nurse initiated vaccine, as Nick's just explained. You know, there's a pretty strict checklist of eligibility. So yeah, so it is just in that GP setting, so we can just establish that the right vaccine is for the right person at the right time.
Yeah, you offer your Pneumovax, but they've also need a shingles as well. So yeah, you basically tell them to go to the GP.
Yes.
Yeah. So you can get them both at the same time.
Yeah.
Yeah.
Okay, any more questions? Do we want to make Anthony run? Oh, over here, yes. He's running, excellent.
I was just going to ask if you can have a 2-dose course of Shingrix, and then should you still get the Zostavax at 70 if you've had the Shingrix as well?
Yeah, I think I'd just stick to the Shingrix.
Yeah, sure. Yeah. So can we be encouraging people to do that early if they want to?
Yeah. I mean, just obviously there's a cost to it.
Yeah.
And I think there's always that question is, should you get it at 51 or wait till you're sort of a bit older? If you've had an episode of shingles, you know, the real shingles, then that will boost your immunity anyway. So you probably can wait a year after a shingles episode before you get the vaccine. Yeah, it's sort of, I don't know. I mean, I think we don't have 20 years experience of how long it lasts yet to say, is it better to get it 52, 53 or wait? So
at the moment, is it just a matter of counselling saying you can have a shingles vaccine now if you like? It's free once you turn 70, but it's a different one. If you want to protect yourself now, you'll have to pay, and just let them make that decision for themselves.
Excellent answer.
Cool. Awesome. Thank you.
I hope that was recorded. That was very good. Then that, if you want to join their webinar next Thursday, they'll probably go into a bit more detail about the efficacy, etc., of the different vaccines.
She might be hosting.
So I think that's all that I've got on Slido. If anyone else has another burning question, we have got plenty of time, but I'm sure everyone likes a early mark too, if that's possible. So
Going once?
Going once, going twice. I'll hand back over to Anthony. Thank you.
Oh, Belinda's had enough. Rightio. For those that haven't taken advantage of it already, at the rear of the room, there is a stack of resources that are available for you and some bags so you can collate them all at the same time. That some are getting picked up right now, just on the table with the pH and tablecloth. There's a lot of work that goes into putting together an event like this. So to Katie Pryor and your team, Katie, congratulations on a wonderful event today. I'd like to thank Securus, Pfizer and the Orange X Services Club for their support of this event as well. And I think the team here at the X Services Club deserves a round of applause, especially if not for those scones this morning, which were amazing and helped me skip lunch, which was great. Might come out half a kilo lighter after today. And of course, our wonderful guest speakers today, we had Katrina Clark online, but of course, Priscilla Stanley, Belinda Tracy, and Nick Wood, who have just been superb for us today. Thank you so much. But also, on behalf of the PHN team, Western New South Wales Primary Health Network, it's because of you that we put on events like this. So thank you very much for attending. It's been great to see you all in person rather than on tiles on a webinar somewhere, which has been really, really nice as well. So thank you for your support on behalf of all of us from NCIRS, from Western New South Wales Local Health District, and from the Western New South Wales Primary Health Network as well. Thank you very much. And that wraps up the 2022 Nurse Immunisation Conference. Thanks so much. Travel safely home.